Hello and welcome to this session of the International Tracheostomy Symposium. This session we're focusing on what patients want and the care that we can deliver to them. First of all, we need to thank the sponsors of this event, our platinum sponsors Smiths Medical and Atos, and our gold sponsors Capitex. And without their help we simply wouldn't be able to do this, so thank you very much. My name's Brendan McGrath. My day job is an intensive care doctor and researcher, and I lead various tracheostomy safety and quality improvement initiatives within the UK National Tracheostomy Safety Project and the Global Tracheostomy Collaborative. I'm joined on the sofa by Kath Doherty, who is a paediatric anaesthetist at the Royal Manchester Children's Hospital, James Lynch, who's an advanced critical care practitioner working in South Manchester, Alan Yates, who's a former patient on our intensive care unit, and Ruth Coleman, who is a trainee advanced critical care practitioner working on our ICU. And Ruth, you're going to look after questions.
We want this session to be interactive as possible for you guys at home. So after each session, we're going to have a panel debate. So please send me in your questions directly through the platform. And remember to hashtag ITS6 and hashtag by the patient for the patient. We're going to be tweeting all day. Thanks,
Ruth. And remember, you can watch any or all of these sessions on demand after this live event. There's lots of information on the lobby, on the platform about how you can get interactive. First up, some of our little friends want to welcome you to Manchester.
So welcome to Manchester. We're going to get right going with this then. So you're going to hear some impressive academic introductions today, but I doubt few will match Alan's. Having studied comparative physiology at the Queen Mary University of London and a PhD in experimental diabetes research at the University of Manchester, Dr. Yates spent 40 years at Manchester Medical School and the Department of Clinical Biochemistry at Manchester Foundation Trust. His research gate has literally been the envy of the rest of our scientific panel, with work spanning diabetes, rheumatoid arthritis, lupus, and more recently anti-Müllerian hormone. Alan Yates is to AMH assays what Brendan is to tracheostomies. But he's not here to talk about that today. Unfortunately, on the 12th of April 2020, Alan made a fateful phone call. Do you want to take it from there, Alan?
Yeah, thanks, James. Morning, everyone. End of March last year, forgive the croaky voice, but we'd entered the first lockdown in the UK. I was retired, I was isolating, I live on my own, but I still managed to get coronavirus. And essentially it all started with feeling a little bit rough. I didn't lose my smell or taste, so at the start I wasn't overly worried. But as the week passed, by the end of that week on Easter Sunday last year, I was so poorly that I had to ring an ambulance. The paramedics arrived, took one look at me, and they were almost unanimous and said, "We think you've got the virus. Went to Wythenshawe Hospital, see you guys. Within a day of being admitted, I was in intensive care on CCU. I was intubated and put on a ventilator, given loads of drugs. I was suffering bouts of AF, so my heart was going 10 to the dozen. My oxygen levels were through the floor. So to say I was a little bit delirious is an understatement. I didn't really have a clue what was going on. So over those first few weeks, I was prone. I was kept on the ventilator. When I started to get some semblance of knowing where I was, I realised that somewhere along the line, the intubation had been swapped out and a trachea had been put in. And at that point, I would sort of slowly gain over the virus. So my last few days in ICU was spent with the physios, getting me out of bed, trying to walk and get some strength back, the speech and language therapists, trying to get me to learn how to put a speaking valve on, and to breathe and speak with a tracheostomy. I was then transferred from there to a recovery ward, which was the Northwest ventilation unit. And I have to say, everyone on that ward is used to people with laryngectomies, tracheostomies. And it was there I got more training in how to look after my own trachea, how to do suctions, how to do the nebulizer. And at that point, before I left hospital, they came along and put a camera down my throat, and it was then I was told that I had this damage to my vocal cords, which I have to say was devastating. I remember having a few tears and thinking I remember saying I was hoping to get away scot-free. Obviously I hadn't. And I must admit, I also thought, you know, what the hell have you guys done to me? Sticking this lump of plastic in my throat. But obviously, when you sit back and look at it logically, if you hadn't have done that, I wouldn't be here on this couch speaking to you today. So, ironically, I'm eternally grateful to you for being so nasty to me. Also, when I was in the vent unit, excuse me, because I live alone, I was going to stay with my sister to recuperate for a few weeks. So she was trained up in the vent unit on how to do the tube dressings, how to clean the stoma, and what to do if, God forbid, anything untoward happened. So we were sent off with an algorithm of it's an ambu bag. Yeah. Just in case the tube got blocked. All my machines and everything got set up in Cheshire, and I stayed at my sister's for 10 weeks. I had community visits there from a respiratory physiotherapist who was excellent. She got my lungs working. She gave me an exercise routine. And after 10 weeks at my sister's, I came back to Manchester, where I live, with all my paraphernalia. And the dressing change duties were then swapped over to the local community care nurses. And that was the one and only mishap, was on the first trachea dressing change. I took my fingers off the trachea when the ties were off, which I'd been taught never to do. nurse took her fingers off, I coughed, and out flew the tube. So it was very quickly cleaned and put back in. And I have to say, in the almost a year that I had the tracheostomy, that was the only mishap we ever had. So once I got over the shock, and more importantly, the nurse got over the shock, it all went fairly smoothly from that. And meantime, at the hospital, my care had been transferred from the ventilation unit to the ENT department. And again, those guys are no strangers to tracheostomies. So they were doing my monthly tube changes. And the surgeon who'd originally put the trachea in came and saw me and said, look, I've had some success in getting people to have their tracheas removed. So in November last year, I had the first procedure where he put a balloon down my throat, dilated it and stretched my larynx. It worked a little bit, but not enough to enable removal of the trachea. But we tried again in February of this year, and that was the turning point, because after that, a couple of months after, once everything had settled down again, I went into hospital. They took the trachea out and left me overnight just to see I was okay. And I was okay. So I was fine, the trachea came out. Unfortunately, I've still got an open stoma that won't close. So that's going to need surgically repairing soon, I hope. But I have to say, that whole journey, just losing the tube once in 18 months is quite a good track record. So I'm very grateful to you guys for doing what you did.
Thank you so much. It's really good to see you doing so well, Alan.
I'm fine, thanks.
I wonder, whilst you were on the intensive care unit, could you tell that it wasn't really business as usual?
Yeah, certainly. I mean, I was very, very ill with the virus. I remember I couldn't hear anything, or I wasn't responding to sound. So communication was difficult. Then when I woke up with a trachea, originally, basically just from the trauma of the surgery, I couldn't talk, my throat was really sore. So communicating with the staff was quite hard at first. But yeah, it was quite a big awakening to realise that, hang on, what's this in the middle of my throat? So yeah, quite shocked.
You mentioned communication there. I imagine that's made all the more difficult by the fact that we've got these big plastic masks on our faces now.
Yeah, I was chatting to Barbara before, and all I remember of all the stuff is basically that. All you could see was eyes. So it was difficult, yeah. It's a difficult time for everyone, I guess. That first wave of the pandemic, especially.
Yeah. I mean, Alan, you've covered a huge range of your story there, and you've basically been through the whole tracheostomy experience, and then you've lived with a tracheostomy in the community, and then you've lived, unfortunately, through a few complications as we try and get the trachea out. Glad to see that it's your journey's almost finished. We really want to focus during this symposium on what we can do as healthcare professionals to help patients like you that, you know, when you get really sick with COVID, it's not going to be much fun, and there's sometimes not a huge amount we can do about that, but there are things that we can improve. And I just wonder, did you feel prepared when you were discharged from hospital into the community with your tracheostomy?
I think so. I mean, there was obviously a certain amount of trepidation about coming out, especially going back to my sisters. I have to say she did a fantastic job as a layperson. So as a consequence, the physios and the nurses on the vent unit did a great job training her up. So we got through that whole 10-week recovery with her without any repercussions at all.
Okay.
And at the time when I first got out, the stoma was quite granular, There was blood in the tube, obviously, so it took a while for it to settle down. And the first few occasions, you know, cross fingers, let's hope there's no problems. Unfortunately for me, there weren't. As I say, for that one small hiccup, and I don't know who was more shocked, me or the nurse watching it on the floor.
Yeah.
But it, by and large, it's been fairly seamless.
Okay.
There are one or two occasions that I think I've encountered more problems since the tube came out in terms of connecting with my GP and things like that. Because obviously the community care's now stopped.
Yeah.
I can look after my own dressings. So getting appointments with GPs, which I'm sure everybody in the country knows isn't the easiest of things at the moment. But yeah, it was quite scary, but yeah, it was okay.
Okay.
It's amazing, Alan, and I'm obviously from a paediatric background, so hearing your story is even more amazing for me. Out of interest, when your trachea was on the floor, who put it back in? You or her?
The nurse.
The nurse. Fine.
With some instruction from my brother.
Fine. Which it must have been.
So she did have it turned the wrong way at first. So we did have to politely tell her to turn it round and put it in.
Oh, bless her. And Alan, I guess it's hard to remember all of the ICU and the transition, but if you could improve one thing that we could do for another patient like you, what would it be? Either in hospital or transition to the community, whichever.
I don't know. It's quite hard because you guys are a centre of excellence. So I think the one thing that not frustrated me was when I was on the vent unit, I had a couple of visits from a clinical psychologist. Mm-hmm. And this was within a couple of days of being scoped and told that my voice box was damaged.
Yeah.
So I have to admit, I was down in the dumps.
Yeah.
And he came along and said, right, forget the person you used to be. You've got to try and concentrate on being the best you can be. Mm-hmm. Great advice. It's part of my mantra now. But I think at the time, maybe slightly mistimed, I don't know.
Yeah.
The miserable me that was that bed wasn't very appreciative.
Didn't want to hear it, probably. Yeah. So that how we deliver that information is really important, isn't it?
But apart from that, nothing really.
Thank you, Alan.
Okay.
We're going to have an awful lot more through the day from our patients. Alan's going to be joining me for a breakout session in about an hour or so over on the other part of the platform. And we're going to be talking just about that, what one thing we can do or what one thing we should be focusing on to really improve care for our patients. We've got Michael Rosen joining us later, who's had a similar journey to Alan. We'll be hearing from him. And Alan's discussed there the Northwest Vent Unit and the multidisciplinary team there. We've got a presentation from Anusha Gupta, a local GP, who again has had a similar journey to Alan. And with her and the Northwest Vent Unit staff describing how they came together to try to get her through that. There's even some posters from patients and patient groups, and we're delighted to have Tanvir with us later, who helped on the scientific session with the judging. So there's patient and family involvement throughout today. Like I said, that breakout session will be coming up soon, and me and Alan will be jumping across to that.
Great. Yeah, great. So now it gives me great pleasure to introduce Tanis, who is a senior speech and language pathologist from Austin Health in Melbourne. Having completed her master's at the University of Colorado, Tanis has worked in the United States, Canada, Australia, and she is a founding member of the director of TRAMS, which is the Tracheostomy Review and Management Service, which is internationally renowned and everyone is super jealous of. It has managed over 1,200 patients since its inception, coordinating what I think is true multidisciplinary tracheostomy care from ICU right through to the community. Tanis is also the Vice Chairman of the Board of Directors for the GTC, and personally, I can vouch that she's a wonderful host if you ever happen to be travelling down the Great Ocean Road. So Tanis, I'd like to introduce you to talk to us next.
Good day wherever this finds you in the world, and wow, I am touched and very humbled by that introduction. Of course, it's a team effort, and thank you. I am so pleased to be part of the 6th International Tracheostomy Symposium, and on behalf of all of our team in Melbourne, Australia, huge congratulations and a very sincere thanks to the organizing committee, to Brendan McGrath, to the patients and family who are going to take part today, to those who put in abstracts and are participating, and of course to those who are attending. It's an exciting meeting and it's a great honor to be here. You see that we have tracheostomy team trailblazers on the right of your screen there. That's Brendan and crew in a tour of Victoria mode after the last ITS. And it's been a brutal couple of years between when we last saw this team and now, but look at them here, cool, calm, and collected, and planning the first inaugural virtual ITS. So love your work, amazing to be here. Brendan's asked me to talk about the Global Tracheostomy Collaborative. That's the patient and family group, and lots of smiles coming your way. That team will all be watching today and joining you around the world. In terms of disclosure, I'm an executive board member of the Global Tracheostomy Collaborative. I'd like you to know that the photos and videos of the patients and families shared by all Austin Health presenters for the 6th ITS have been used with written consent from patients and families. I like this photo. It always makes me chuckle, and I call it the COVID fog. And it's been a heck of a time since we saw the team in 2019. So the term VUCA, you might know, it was first coined in the Cold War, actually, and it talks about a culture that has volatility, uncertainty, complexity, chaos, and ambiguity. And is in fact creates a lot of challenge on many fronts. And in 2021, it feels like maybe we're still in VUCA, but hopefully the fog is lifting. And I'll talk to you a little bit about that at the end of this talk. So the ITS6, the tagline is for the patient and by the patient. I think it's brilliant. Brendan's asked me to speak about the Global Tracheostomy Collaborative, who we are, what we've accomplished, have we made a difference, and what are our future directions. So in 2012, about 10 years, there's been a lot of changes, but the universal tracheostomy challenges were patients and families were not consistently consulted. There were high numbers of avoidable and preventable deaths. There weren't many coordinated tracheostomy teams. There was lack of education, policy, procedure, and certainly a paucity of data with only a small literature base. But of course, the trailblazing team from the UK was leading the way and showed us in this report 23% of all ICU or 31% of ward-based tracheostomy patients came to harm. They established the National Tracheostomy Safety Project, which has been of great value to so many of us. In St. Mary's Hospital in London, they started a care bundle of tracheostomy care procedures. They audited at that. And then with the multidisciplinary team round in place, they brought the incidence of risk way down. The Australian experience was similar. TRAMS model started in 2001, and we published in 2009 on the outcomes of our team. There were a lot of tracheostomy teams in Australia, and Speed and colleagues in 2013 published tracheostomy teams reduce tracheostomy time and increase speaking valve use, a systematic meta-analysis. The meta-analysis found similar outcomes with tracheostomy teams associated with reductions in time to talk, length of hospital stay, and length of ICU stay. There are numerous tracheostomy teams in place in Australia, but we were looking in 2011 to other world leaders, and we hosted a 2011 inaugural ITS. And at that point, we had 90 hospitals attending our meeting and 49 tracheostomy teams associated with Asia Pacific region. The US experience was certainly similar. Dr. Brendan McGrath, Michael Brenner, I apologize, talked about multifactorial systemic changes leading to a preventable death of a tracheostomy patient at his facility. And it was a Swiss cheese kind of problem. You know, there was ICU staff shortage, the intern lacked airway experience, and the anesthesiologist was in the OR. There was communication breakdown. The US went on to publish several early papers. And on the background of that, the Global Tracheostomy Collaborative was established in 2012. At the time, Dr. David Robertson and Dr. Tony Narula called about 21 multidisciplinary tracheostomy specialists from around the world to meet in Glasgow, and we created a world-first tracheostomy quality collaborative. We created a vision and a mission, which sounds easier than it was, and it was probably challenging, but in the end, I think we've got there, and I hope that you will agree as we move forward today. We established an executive committee, a board of directors. We became incorporated in the US not-for-profit, and we created a website. So Michael Brenner is our current fabulous CEO and president, and we have many, many very busy and productive committees. And I have to say that this is pretty remarkable work because it was all done on a volunteer basis. There's a picture of Dr. Robinson. David is our GTC founder and visionary, and he's always most comfortable at home with patients and families. And you see him in our ITS in 2014 and again in 2019. And I really like that picture of David with our one of our very dear patients, Sally. We adopted key drivers that really reflected the universal challenges, and those are the patient and family consultation at every turn, the multidisciplinary teams, coordinated policy procedure, education, and importantly, the database entry analysis and reporting became a new and very important part of our work. So here we are in 2021. Who are we? Who are the GTC? Well, I think together, every one of us have become tracheostomy leaders and influencers. And I like this definition of leadership. If your actions inspire others to dream more, learn more, and do more to improve this world, then you are a leader. And there are a lot of thought leaders right now, Brene Brown amongst others, who talk about vulnerability and the concept of having to be unusually authentic, accepting failure as part of success, the concept that you have to be in the arena, you need to take risks to make change and make a difference. And I think the GTC has done all of that, all of us together. We have been growing and connecting and increasing our membership numbers. I'm delighted to report that we now have 250 patients and families connected around the world. We have about 35 hospital members. That number's down slightly since COVID and some of the financial challenges. And we have over 3,700 healthcare professionals. Very exciting. I have to comment on our accomplishment of the GTC database. It's a robust database that's recently had version 3 rollout. There are now almost 9,000 patients entered across 51 sites, and a huge thank you to the CAPQA team, which is Dion Graham and Carly Milligren. CAPQA stands for Center for Applied Paediatric Quality Analytics, and you're going to hear from that team later on today. They receive, our member hospitals receive reports, and it's simply tremendous teamwork that has gone on there. Likewise, the GTC webinar series. Look at this huge repository that's up on our site, and it is talking about multidisciplinary teams around the world in a very professional way, bringing updates in real time about what's hot, happening, and important in the world of tracheostomy care, including many patients and families being involved. We're incredibly proud of this work. We have, of course, had 6 International Tracheostomy Symposiums, each uniquely inspiring with a growing patient and family focus. I'm also pleased to talk about continuing conversations that count, and shortly you're going to hear from Lucy Benactor at the Austin Hospital, who in collaboration with the GTC will talk about a tracheostomy patient and family forums that are also growing in exciting work. Publications have increased dramatically in the last 4 or 5 years, and I'd like to highlight some news from our recent publication involving many of the original GTC members, highlighted by Dr. Brenner and Dr. McGrath. So thank you so much. This work shows patient outcomes of more than 6,500 patients globally across 62 institutions in 6 countries. It outlines the organizational structures and it acknowledges and addresses knowledge gaps in tracheostomy care. After exclusions, we reported on the prevalence of adverse events in over 1,100 pediatric patients and over 3,400 adult patients. The characteristics of this patient population are reported: predictor of adverse events, mortality, length of stay, and index to patient characteristics, comorbidities, and risk factors within context are reported. In terms of course of care, we know now that 92% of patients in our database were admitted to ICU. 85% were ventilated at some point during that stay. 55% were decannulated prior to discharge, and 86% survived to discharge. Importantly, 18% had more than one adverse event during their stay. Adverse events, this shows comparison of adult tracheostomy related outcomes across countries, and the countries are Australia, US, and the UK. Of course, when we're looking at decannulation and mortality, we see that Australia and the UK have higher numbers that are significant compared to the US. And in looking at the data, we recognize that with such diverse healthcare systems and with such difference in reporting across countries, that these results can be shown. Certainly, we do know that in the US, most patients are discharged from acute care center to long-term care facilities much sooner than they are in Australia and the UK. We reported on adverse events per 1,000 tracheostomy days, and on the left you'll see the standard adverse events that most of you are familiar with. And we do know that accidental decannulation, for 67% of the tubes are replaced uneventfully, but 2% result in permanent hypoxic injury or death. It's really significant. Hemorrhage, defined as excessive bleeding in the clinical opinion of those who reported it, is an extremely interesting outcome that we had not expected, to be honest. It's a great example of the power of data to uncover latent risk, in this case, a risk association between bleeding and mortality. It became an important predictor of clinical outcome, really. And in adults, we know that major vessel erosion and local wound breakdown and granulation lead to bleeding. If you've seen one of those major vessel erosions, you don't forget them. Analysis shows that a stepwise trend toward increasing risk with increasing comorbidities, significantly so with more than four morbidities, and tracheostomy to facilitate ventilation or loss of airway increased the risk of hemorrhage. So have we made a difference? Well, we've certainly been in the arena and we've ushered in change. We've tried hard. We've met multiple challenges and setbacks. We've inspired, innovated, and improved care, and we've created exciting tracheostomy communities. We've listened, learned, and leaned on each other and lived through waves of a pandemic. So is the fog clearing? Do we have better vision now? Can we see the future? Well, I think the future direction is really about continued leadership and influence. We need to welcome change and reimagine things in different ways. I think that's what today's meeting is all about, finding the courage to take on new challenges, take risks, put patients and family first, and keep moving forward. Now, this last quote, I think, could be said with a nod to our friend Ted Lasso, who talks about kindness spreading faster than COVID variant around the world. I like this quote. It says, "The strongest people are the ones who, after the world has torn them apart, are still kind." And I think that's talking about our patients and families. I'm just amazed and humbled about how many patients are willing to share their stories and their wisdom. We know that from listening to our patients, patients in the community can thrive if they're well supported, but tracheostomy safety in the community is still critical. We have a long ways to go. The GTC learning community is an important part of care. We wish you all the best in today's exciting endeavor for the ITS, and we look forward to more learning together. All the best from all of us in Melbourne.
Thanks ever so much, Tanis, for another really interesting talk and a great look at a time before COVID. So any questions can be sent in to Ruth, and we'll ask those at the panel discussion at the end of the presentations. And you can go to the GTC booth in the forum for more information. So now it gives me great pleasure to introduce my good friend and colleague, Mr. Neil Bateman. He is a consultant ENT surgeon in Manchester. He's also one of the founding members of the GTC. Neil's interests are pretty diverse, I would say. Clinically, they include airway surgery, safe trachea care. He's part of our MDT trachea team in Manchester. He's also part of the NTSP Paediatric working group. But his interests reach further than that, really. They also include healthcare for children within Greater Manchester. He's the clinical lead for the Children's Recovery Group, so he has an interest in equity of healthcare for children throughout the region. So it gives me great pleasure to hand over to Neil. Thanks, Neil.
Hi, so my name's Neil Bateman. I'm a consultant paediatric ENT surgeon here in Manchester at the Royal Manchester Children's Hospital, and I've been asked to talk about children and tracheostomies and COVID-19 and how all of that has worked together. So what I'm going to talk about is children and tracheostomies in very general terms, the COVID pandemic and its effects on children and tracheostomies, and then what can we take from this to try and learn to make things better. So the first thing to say about children and tracheostomies is that children are not small adults. They have a different physiology and they have a different spectrum of disease. And in terms of tracheostomy care, the reasons for them having a tracheostomy are different for the large majority of them to adults. We are familiar with the majority of adults who are in hospital and end up with a tracheostomy have weaning tracheostomies. I realize that they have tracheostomies for other reasons as well, but the majority are on the ICU and get a weaning trachea and are discharged home without a tracheostomy. Most children who have a tracheostomy are discharged home with it. It's really unusual that we do a weaning tracheostomy and send the child home without a trach. So the spectrum of issues is, while it's similar to adults, the emphasis is very different. So this is an extreme example of this. This is an exit procedure, which stands for extrauterine intrapartum procedure. This is a child who was diagnosed antenatally with a large obstructing tumour, which was actually benign in the neck, and we knew that we weren't going to be able to get an airway easily. So we deliver the baby's head and shoulders with the still on placental support, and this is one of my colleagues trying to see the larynx and get an airway. When they were unable to do that, we aspirated one or two of these cysts, and I was able to do a tracheostomy with the child still half in and half out of the uterus. So, you know, that's a rather extreme example of how children with children's tracheostomies are different to adults. And of course, this child went home with their tracheostomy. Even though we excised the tumour, it was not felt that it was safe to try and decannulate the child because of the long-term effects of the tumour. So why do children get tracheostomies? Well, as we've said, airway obstruction is a common reason, and more children are getting tracheostomies in our practice because of the need for respiratory support, either tracheomalacia or neurological problems. So the tracheostomy is used as a portal for long-term ventilation at home. So here are a couple of examples of airway obstruction. On the left, we have acquired subglottic stenosis. As you can see, there's no airway there. Both of these children have got tracheostomies, which is why I'm being so calm when I'm scoping them. And on the right, we have a case of grade 3 congenital subglottic stenosis. So this was a child born with a pinhole airway. And on the left, the child was intubated for a period of weeks after birth and just scarred and stenosed up. So that's a very common cause of airway obstruction in our practice. And probably more commonly, our tracheostomies are done because of the need for respiratory support. So this is a child with really very severe tracheomalacia, secondary to a now repaired tracheoesophageal fistula. And this child is going to at least need a tracheostomy to stent open that airway. And in a lot of cases will also need some long-term ventilation. So what does this mean from a practical point of view? What it means from a practical point of view is that most children need a period of time before their tracheostomy can be removed. And this is mostly measured in apologies for the car alarm. This is mostly measured in years. Most of them actually go home with a tube, and that means that we have to put in place for all of these children home care, care in nursery, and care in education, and that is a big part of paediatric tracheostomy care. So thinking about COVID-19, I think when I look back on it, and it's been a really fascinating, interesting, and of course distressing and difficult time. Initially, I think you can break it down into three phases. There was a phase of high anxiety and frankly panic in some quarters, and the need to protect ourselves as healthcare workers and the need to protect our families and our patients. And after a little while, there was a really concerted effort to return to some kind of normality, which people have termed the new normal. And then after that, there was, and what we're facing in the UK now, and I realise that other countries may be at different points in this, is we're really facing a time where we're having to plan for the future and trying to get over some of the effects that the COVID pandemic has caused on our society and our healthcare services. So March 2020 was a fairly dark time for the country. We had our esteemed Prime Minister, Boris Johnson, announcing a lockdown where we were told that the most important thing was that we protect the NHS and everybody stays at home. It was a time that I don't think anybody who went through it will ever forget. A significant proportion of the country seemed to think that what they needed at that stage was a year's supply of toilet rolls. So there was panic buying, and the shelves of most supermarkets were empty of toilet rolls. And the country really was facing a very unprecedented disruption, and there was genuine fear and concern all around. And I would say none more so than amongst ear, nose and throat surgeons or otolaryngologists, because it became apparent very quickly that ENT surgeons were at peculiarly high risk of contracting COVID-19 in the workplace. And there were people who suggested that ENT surgeons seemed to get worse disease and do worse. So this was a paper published in the International Archives of Otolaryngology, which related one of the first cases of COVID spreading in Wuhan, and this related to a endoscopic sinus surgery procedure. And I'm not sure actually how true it is, but the description is truly frightening, that because of the aerosols generated during the procedure, everyone in the operating room caught COVID, and a significant number of them did very, very badly indeed. And it was this sort of thing that really startled and created a significant amount of anxiety and panic amongst my colleagues, myself included. And that was compounded when a really well-respected and well-loved colleague of a number of my friends who work in the West Midlands died of COVID-19, and he was the first healthcare worker in the UK to die of COVID caught in the workplace. And this really meant that we were, and this was in late March, and this really meant that everyone in hospitals and ENT surgeons, as much as anybody, were incredibly anxious about the idea of catching this disease in the workplace. And at that point, the idea of an aerosol generating procedure became something that everybody was talking about, and not something anyone had really considered up until then. And numerous surgical procedures were designated aerosol generating procedures. As an airway surgeon, pretty much everything I did was designated an aerosol generating procedures, an aerosol generating procedure, and all of these required aerosol level PPE and also isolation. Now, in terms of tracheostomies, pretty much everything you could do to a tracheostomy was, apart from changing the tapes, was designated an aerosol generating procedure. So changing the tube, doing suction, and of course, what this had was, on the top of a really isolating event where everybody had to stay at home, a really isolating effect on children with tracheostomies, both in terms of their healthcare, their education, and their normal life. So in the initial, what did the NTSP do? And in the initial phase, the National Tracheostomy Safety Programme, really, it was a fantastic example of collaboration of clinicians from multiple centres and multiple disciplines, produced a really fantastic document in very, very short time, just to give some advice with regard to paediatric tracheostomy care and long-term ventilation care during the COVID pandemic. And it's a really good document, and it was just really heartwarming to be involved in producing that, because all of my colleagues from around the country really stepped up. And the next phase was really about returning to some kind of normal. And what the NTSP did at this point was to try and support people in being able to recover back to a new normal. And in children with tracheostomies, that was all really about return to education. And the main focus of that was in trying to address some of these issues of the effects of doing aerosol generating procedures, or supposedly aerosol generating procedures, on children with tracheostomies. Because Public Health England had some rules whereby if you had a child with a tracheostomy in the classroom, they needed to be isolated for suction, they needed full PPE for suction, and of course what this meant is that it was completely impractical for children with tracheostomies to return to school. So we set about challenging Public Health England's policies, and basically with a message that tracheostomies don't spread COVID-19. Children did not get a lot of serious disease with COVID-19, and children with tracheostomies were no more likely to get it or to spread it than children without. And so my colleagues in Great Ormond Street did some fantastic work looking at aerosol droplet spread, and compared children coughing with and without tracheostomies and suctioning of tracheostomies, and showed that actually it was the amount of droplets, the amount of aerosol spread that you got with suctioning a tracheostomy was tiny compared to a child coughing. And also emphasised the use of the tracheophone device, which is a really good bit of kit to suction through to minimise any aerosol spread. And so we produced a series of videos, which was that's me with my lockdown hair being videoed in our hospital, just talking about tracheostomies and the sort of just the effects of isolation on children, and how we would propose that was addressed, and just trying to get some kind of equity of access for education for children, because that has been a major problem for children over the course of the COVID pandemic. So what happens next? Well, I think it's really important that we recognise that COVID has changed the way we work, and in a lot of instances it's changed the way we work for the better. In our hospital, it has accelerated a lot of things that we do, which actually when we look back on it, we should be doing anyway. We have initiated remote consultations, and that has revolutionized the way that we deliver results and prevented people from having to drive several hours to the hospital just for a 5-minute appointment. And it's incredible we didn't do that before. We've developed a patient-initiated follow-up system so that people are only seen when they really need to be seen. And that's been on the back of COVID, because we don't want waiting rooms full of people unless we need them. And within our hospital, we've developed a walk-in, walk-out surgery system so that patients are able to come to hospital, come to the theatre suite, have their surgery, be discharged home, and not be dependent on an inpatient bed, even if they're a day case. So all of this has allowed better patient-centred care, and a lot of this has come about directly because of the COVID pandemic and the need for recovery from it. So thank you very much. It's been a pleasure talking.
Thank you so much to Neil and to Kath that work with the Paediatric Working Group on the NTSP. They've really gone above and beyond to advocate for their patients. Please keep your questions coming in to Ruth and through Twitter using the hashtag ITS6. My next job is to introduce Brendan McGrath, who's on the sofa with us. Brendan is the NTSP chair. He's the NHS England lead for tracheostomy care. He's now a professor. He's got the Royal College of Anaesthetists Mackintosh Professor, the Association of Anaesthetists Featherstone Professor, the Difficult Airway Society Professor of Anaesthesia and Airways, and he's also a visiting professor at Harvard Medical School. Brendan, over to you.
Thank you for the introduction. I've got a few jobs around tracheostomy care, and I'm going to talk about some work that we've done in 20 sites in the United Kingdom, which led on to a national patient safety improvement programme around tracheostomy care. All of these different jobs still mean that I fortunately don't have any interesting declarations of interest, and everything that I talk about you can find out by typing the word tracheostomy into Google, UK if you work outside the UK, and you'll find the website of the National Tracheostomy Safety Project, where all of our resources and information is kept. So what I'm going to talk about? Well, a little bit about why we all need to know something about tracheostomies. What problems can you have with tracheostomies? What do our patients think? And importantly, about collaboration and quality improvement. And I'll signpost you to some of the resources that we used in our United Kingdom programmes. I hope by the end of the talk, you'll be thinking, why aren't I doing this already? Some of you will already be doing this, but hopefully by showing what we were able to do at scale in the United Kingdom, you realise that these challenges are actually doable. Of course, we'll touch on COVID, which is actually a big driver for improvements in tracheostomy care, interestingly enough. Okay, so why do we need to know a bit about trachees? Well, we come across tracheostomies in all sorts of different places. So typically where I work on the intensive care unit, but if you do work in operating theatres, either as a surgical team or on the anaesthetic side or on the wards afterwards, you're going to meet patients with tracheostomies and laryngectomies. You may be involved in insertion of tracheostomies, and you might meet people on the wards or the outpatient clinics or in the community who have tracheostomies. We even have lots of little people who have tracheostomies, and of course they need their own special set of resources. So why is this relevant? Well, patients with tracheostomies are often complex, and complex patients often need complex care and complex teams around them. And whenever you've got lots of different teams working together to keep someone safe, that means we're all interdependent on each other, and that can bring its own problems and need some coordination and often a little bit of guidance. So what sort of problems can you have? Well, we've published a lot on this, and I'm sure a lot of this work is familiar to you, but the work we've done in the UK and Europe has been replicated in other places around the world, and we've all pretty much seen the same sort of thing. Themes around problems with education, a lack of staffing or a lack of appropriate staffing or appropriately trained staff, the equipment of provision, which can be in an emergency a real problem. Some of the infrastructure and support mechanisms for keeping our patients safe can be lacking. Often a lot of our resources, particularly in hospital, are knee-jerk responses with a lack of patient focus. And all this leads to preventable harm. And whilst the harm is preventable, it actually means that it's amenable to some prospective quality improvement strategies, which means we can do something about it. We started off with our work thinking, well, how are we going to manage an emergency? Because it was pretty clear that tracheostomy and laryngectomy emergencies were happening in hospitals and staff didn't know what to do. So that's where we started. Some of these algorithms and bedhead signs will hopefully be familiar to you. And these are a one-page, one-stop shop of how to deal with the vast majority of tracheostomy emergencies. Paired with the bedhead signs, it tells you what you need to know immediately about that patient's airway. If you haven't got an airway, if you've had a laryngectomy, then clearly things are different, so a slightly different approach. And again, if you are a child with a tracheostomy or a baby with a tracheostomy, the approach is slightly different again. So there's guidance being published for all these different scenarios. Importantly, we're able to get endorsement and support from loads of different organisations in the United Kingdom. And that not only meant we had buy-in from these organisations, but it meant they could help us disseminate these resources when the time came. And that was really important in getting everyone on the same page when it came to improving tracheostomy care. We supported our resources with e-learning modules on our national platform in the National Health Service. We've written a couple of books about these things, and we've got loads of different videos and easily accessible resources like this that show you what to do in both routine care and emergency care. And these videos are used ad hoc for training at the bedside, in the communities, in operating theatres, ICUs. It means that instead of having to look at great big textbooks, we can show people quickly on our smartphones what to do, and you can remind yourself of some just-in-time training just before you meet a patient. Of course, you've got to have an app nowadays, otherwise it's not a proper project, and you can download our app for free with all these resources and bits of information on. So what about the important people? What do patients think? Well, this is Bob, who was our tracheostomy patient champion at the hospital I work in for many years. Bob contributed to some national guidance, and Bob told us a very insightful quote. He said that our patients assume they're going to have safe care when you go into hospital, but they expect high quality care. And what he meant by that was if you go into hospital, you don't expect that the staff are going to need training in how to keep you safe. You just assume that everyone knows what they're doing. And actually what patients want is sometimes very different to what we'd spent 10 years trying to develop in our hospital systems. So if we look back at our journey over the last 15 or so years with the National Tracheostomy Safety Project, we started off trying to reduce harm from emergencies by focusing on training staff and supporting staff in delivering safe emergency care. But clearly, the real money is in stopping those emergencies happening in the first place and preventing them through basic care done well. But then as we got our patients more involved, it was clear that actually we wanted to be delivering high quality care. And that became more and more important through these partnerships and the work that we were doing as time went on. So before we started on our big 20-site project in the UK, we looked at where we were. So we had a reasonable understanding of what the problems were. We also had examples from all around the world, exemplar hospitals that had shown the way, how to make care better and how to improve things. We'd also seen the fledgling Global Tracheostomy Collaborative come on the scene in about 2012 and start to collect data and show that improvements could be made and made effectively. And that led us on to some small pilot site analysis, which were invited to scale up with the Health Foundation up to a 20-site project in the UK. So that's what I'm going to talk just a little bit about, and obviously you'll hear a lot about the Global Tracheostomy Collaborative today, and there's a couple of papers you can read about the work they were doing, and that's what we tried to implement in our programme. So what did we do? Well, supported by the Royal College of Anaesthetists and funded by the Health Foundation, we decided to set about trying to implement those key drivers of the GTC into these sites in the United Kingdom. Our aim was to improve the quality of care, the safety of care, and by doing that, we thought we'd also improve organisational efficiency. But importantly, we wanted to learn how to make effective changes, what worked well and what didn't work. 20 sites up and down the United Kingdom, 2 paediatric tertiary centres, big hospitals, small hospitals, Scotland, England, Wales, all over the place. But we were supported, importantly, by this network of hospitals all around the world through the Global Tracheostomy Collaborative, and that was really important in getting these changes made. Fairly standard plan, do, study, act methodology, nothing new there, but we tried to put these key drivers in place. So truly multidisciplinary care, trying to standardise care, broad staff education as best as we could, with the goal that every doctor, nurse or healthcare provider had been trained in how to look after somebody with a tracheostomy. Real involvement and engagement with patients and their families, making sure that anything that we did that involved patients had been decided by them. And then, of course, using data to drive improvements. We made these changes in 3 different groups: organisational changes, quality changes, and safety changes. We did lots of measurements, and I won't go into this in too much detail, but we looked at patient experience. We spent a lot of time interviewing and videoing and recording our patients to try and get some qualitative data that we could then support some of our quantitative metrics. We looked at anxiety and depression because that was reported by our patients as being important. And we collected a lot of data that you'll hear about later in the symposium, looking at the way that we could influence our staff and the way staff responded to the challenge, because we wanted to learn how to make changes so we could bottle that up and use it when it came to disseminate this information. We also use some innovative methods of trying to target our staff at the bedside, which we've written about, and you can look these papers up.
You've tried to speak, tried to shout for somebody, and nothing comes out.
Frightening. It's frightening. Suddenly you can't talk anymore. It's a big loss.
Can't have, it's gone.
And by getting this idea across the staff at the bedside, this patient perspective, imagine what it's like if you wake up and you can't speak. We got staff to really engage with our programmes. So what did we find? Well, 20 different sites, 18 interventions, 1,500 staff and about 2,500 patients. Did the sites do anything? Well, fortunately they did. We were able to reduce the variation in care, and it took about 6 to 12 months for the sites to really make the changes, but things happened relatively quickly. We tracked what interventions happened and when they occurred, and so we could profile which the interventions were easy to implement, easy to sustain, and which more difficult. So now we can focus our energies if we've got to do this again. In terms of safety, we saw a big reduction in the nature, frequency and severity of patient safety incidents. Over 50% reduction in the severity of harm over the course of the programme. What else did we find? Well, if you scale this programme up, we estimated independently that we would save about £275 million for the UK NHS. We saw a huge reduction in patient-reported anxiety. We saw a 20% reduction in length of stay, and we estimated that we'd save around 170 lives per year in the English NHS if this programme was rolled out. And they aren't my figures, they're somebody else's. We supported these claims by talking to our patients, and this is a quote from a patient saying, well, it was like being admitted to a different hospital when she came back in to the same ward after they'd undergone comprehensive training. And that was supported by the metrics we saw, with a 50% reduction in patient-reported anxiety, which is huge if you're worried about coming into hospital, not being able to speak and being dependent on someone else to keep you safe. But then the quality of care was also improved. We looked at loads of metrics about eating, drinking and talking, and we really tried to focus hard on disseminating strategies, particularly through our speech and language therapists, to get people talking.
2, 3, 4, 5.
Can you say the same again, Tammy?
1, 2, 3, 4, 5.
Okay, hello.
Hello. Got a voice.
And you can see what that means to our patients when they learn to speak again and get talking to their loved ones and the staff around them for the very first time. But we saw some huge changes in time to first speaking valve use, time to getting the cuff deflated, and time to first oral intake, which is what patients were telling us they wanted us to try and achieve. All about this, you can find all this on the NTSP website or by diving into PubMed. And what we wanted to do was take the results of this programme and roll it out across the country. Now, we were in talks with NHS England about doing this when, of course, COVID came, and we realised we're going to have a pretty rapid surge in the numbers of patients requiring a tracheostomy in the intensive care unit. So we had this programme oven ready, as our Prime Minister would say, ready to go. And so we were able to rapidly roll this programme out. It was interesting trying to find a balance between protecting the staff and benefiting the patient. And a lot of the initial responses to COVID were around delaying tracheostomy care and preventing some of the interventions that we know help patients, but do increase the risk for staff. And throughout this symposium, you'll hear about this tension between being proactive and benefiting the patients, and perhaps being cautious and protecting our staff. And some of our speakers later on will really try and explore these difficult balancing acts. We used a lot of data to try and understand what's the right thing to do for the right time for our patients. And I think, as you'll hear from Steve Warrilow later on, I think we've evolved back to pretty much business as usual. We wrote up a lot of this guidance in the United Kingdom, and a lot of it was extrapolated from some of the national and international work that we'd done with colleagues. And that was another great thing about working with the collaborative, that we can really lean on these connections that we've got all around the world, and we can bring that into the health service that I work in, but also learn lessons to spread all around the world. So thank you for listening. I think what we've achieved in the United Kingdom is patient-centred care that has improved the quality and safety of tracheostomy care for all of our patients. Thank you.
Right, so I'm delighted that we're now joined by Tanis, who's down in Melbourne, and Neil, who's not too far away in Sheffield, in the north part of the United Kingdom, for a panel discussion about those presentations that you've just seen. So I'm going to hand over to Ruth and see what questions have been coming in.
Firstly, thank you for all your questions. They're really interesting. Alan, we've got a couple for you to start, if that's okay. Our viewers just want to know, like, are you eating and drinking now, even though your stoma isn't completely closed?
Yep, I can still eat and drink normally. I think my surgeon took a softly approach, which is why it's taken 2 operations to get to where I am. He didn't want to overdo it because there was a danger of losing my swallow. But at the moment, everything's fine.
And how long did it take for you until you could start eating? How long was the process?
It was pretty much towards the end of my stay in ICU.
Okay. I
seem to recall the nasogastric tube coming out and somebody throwing a piece of toast at me.
Oh.
And I have to say, ice cream was a godsend. It was fantastic.
Another question that we've got, Alan, is, looking back now, what advice would you give to a patient who was in your shoes?
Try and stay calm and carry on, I guess. It's very daunting waking up with such a change to your body and knowing, obviously, with me, the biggest damage was done by the virus, by the COVID. So recovering from that and then getting to terms with having a tracheostomy in was quite a big deal. It takes a while to get your head round it, but stay calm. Things will work out.
Lovely. Thanks, Alan. Okay.
Brilliant. Yeah, I've got a question for Neil, actually. Hi, Neil. Thanks for your talk. It's grand. Neil, you talked about the acceptance of children with tracheostomies during COVID and the misbelief that they were COVID spreaders by their masses of aerosols spurting out of their tracheostomies. How does that fit with your walk-in, walk-out model? Have they been excluded from there as patients, or have we been accepting of them?
So as you know, it's something that we have been accepting of. Sorry, there's a bit of a delay on the line. We've got to the point where we're able to accept them now, but it has definitely been a sort of a struggle with our hospital. And I think this goes back to the what Brendan was just saying about sort of difficulties, the conflict between providing a really fantastic service and protecting staff. And so I think we've certainly got to a point where we can accept that patients with tracheostomies, children with tracheostomies, are no more likely to spread or contract COVID than children without tracheostomies. But yeah, you know, there has been undoubtedly, and I'm sure it's the case across all hospitals, this kind of conflict between the need to protect staff and the need to provide good quality care. And I think back in March 2020, it was really obvious that we needed to protect staff. As things have evolved, I think we've had to move to a position where the quality of care it takes the sort of first precedent.
Great, thanks, Neil.
And Neil, just following on from that, the viewers just want to know, like, where can they get more information about this kind of walk-in, walk-out surgery for children?
So we've produced some videos actually of our walk-in, walk-out service, which we're distributing among Greater Manchester, and we're hoping to distribute that to more on sort of more widespread, on a more countrywide basis. But I mean, if they were to contact me or Kath at the Children's Hospital in Manchester, we'd be really happy to share whatever details we have.
Thank you, Neil. Tanis, there's quite a popular question for you. The viewers want to know, why is there such a big difference between the outcomes between the UK and Australia, especially regarding like decannulation and outcomes?
I think it's a really interesting question, and we on our version 3 are trying to approach some of these things and make sure that we're discussing amongst ourselves some of those questions. In the vast majority of cases, member hospitals have a case mix that might be unique. And our unique case mixes in Australia might be long-term spinal cord injury or long stayers in a ventilator weaning unit, and it might be a different case mix again overseas. And my guesstimate is at this stage that the case mix variation hasn't been able to be reflected on at this stage with our data outcomes. We're working on that, and we're looking forward to hearing again from our colleagues from the GTC who are going to go into the database in great detail later on today.
Thank you, Tanis. Brendan, a question for you. Over the last 18 months, there's been reduced staffing, more surgical trachees, more difficult airways due to like high BMIs and proning. Have there been more incidents and complications during the last 18 months than usual?
Well, that's a really good question. That's something we're really worried about, which is why we put together that programme and why NHS England picked it up and rolled it out. And you're going to hear a little bit more about some of the data from some of our speakers later on in the programme. What we've seen from a quick look at the incidents that have been reported through our established incident reporting systems in the United Kingdom is that the incidents, the frequency and the nature of the incidents reported has been pretty much the same. And that's in the context of the numbers of patients pretty much doubling. Now, as Tanis has alluded to, our data collection in our country and lots of other countries around the world is not terribly robust. But where we do get the data from, that data is probably collected fairly consistently. We're a bit worried in COVID with everyone being so busy that perhaps we didn't report the numbers of incidents that we normally report. And there's some suggestions anyway, we only report maybe about 10% or the tip of the iceberg of things that happen. But certainly, to answer your question, that the reporting of incidents seems to be similar despite a big jump in the numbers of patients. Now, unfortunately, we're well aware of still some significant harm that occurs. And you know, Alan's explained his journey where we have all these potential complications and problems that can occur at any time. But what we wanted to do is to try and make sure when a patient is cared for anywhere in hospital or anywhere in the community that they're supported by staff who are trained, equipped and with the infrastructure to help them deliver that safe care. And when we set up makeshift intensive care units and we were looking after patients in locations that we wouldn't normally look after them, as the person asking the question highlighted, we were doing surgical tracheostomies where we might be doing percutaneous ones, typically in the ICU, so different case mix. But I think despite all those problems, I think we achieved our objective of delivering safe care. And as Neil's highlighted, I think the challenge for us now is to deliver high quality care. And hearing stories like Alan's about some of those transitions, and I know we've got a lot of work to do still in the community with some of Kath and Neil's work to try and make this sort of quality of care equitable and everywhere. But I think in the pandemic, considering the problems we were faced with, I was relieved, should we say, to see that we've not seen a big spike in safety incidents.
Okay, thanks, Brendan. Another one for Brendan. What do hospitals get for joining the Global Tracheostomy Collaboration?
Well, I might ask Tanis to answer half this question as well. But, what we've gained from it is a database to track our activity. We didn't even know how many tracheostomies we did in our hospital, and so having the database to collect that data was critical. And the collaborative is a community of people trying to do what we're trying to do all around the world. And one of my first exposures in the collaborative was a trip to Melbourne to see Tanis, and I think that's had a long-lasting effect on me and some of the work that we've done. So Tanis, I wonder if you could perhaps elaborate on what sites could perhaps gain from joining the GTC beyond some of those data questions that I've just explained. I think Tanis.
Thanks so much.
Oh yeah.
Yes, thanks. It looks as though my battery is not charging, so I'll fix that momentarily. Look, I think totally the community that Brendan has mentioned is the biggest bonus for most of us. Certainly in Australia, we have twice a year meetings with those members who are hospitals. We can we compare data, we talk to each other, we're saying what's working, what model didn't work. How do you go up to your executive? How do you use the reports to showcase the great work that you're doing, and how do you become an international player on the scene that's really making a difference to care? The patient and family network is very, very strong. We've got about 250 patient members, and you'll hear later on from Lucy Bonactor when she talks about the patient and family forums in Australia. They are now part of the Global Tracheostomy Collaborative, and we have patients in Australia talking to patients in the UK. It's very wonderful thing in that way. Many of our hospital members actually didn't realize that they could connect their patients and families who they've sent home to the community to the global group, and that's been a real eye-opener as well. Brendan's mentioned the database, which has been really interesting when we're looking at risks and comparing with hospitals. So I think all of those things, and particularly the collegial aspect, the aspect of being able to publish with other like members, hospitals, that's all been a very big advantage to us.
Alan, another one for you. How are you able to obtain all the equipment you needed at home? And was there a plan when you were home that if anything broke, you knew who to call and how you would get hold of like new equipment?
Yeah, the equipment setup was all done essentially through the hospital by contacting the community nurses. They supplied some of the dressings, for example, but also Atos set up an account for me so I could go in and order suction tubes, various sterile dressings, and they would come essentially whenever I ordered them. So I could order direct from Atos, and that would go presumably to the GP for charging. In terms of the hardware, the nebulizer and the suction machines, they are set up. They were set up for me when I moved to my sister's. Excuse me. And then there was a number to call for the service teams if anything went wrong, which it hasn't done yet. I still have those machines, but they will go back eventually once I get everything closed off, as it were.
Neil, do you feel that COVID in some way has improved how your system works now?
There's no doubt, I think, that there are things which we had always thought we should do, and there were obstacles in the way which COVID, or the need to recover from COVID, have removed those obstacles for. And I keep coming back to the walk-in, walk-out surgery that we had in that we now have in the Royal Manchester Children's Hospital. But I can really vividly remember sitting in meetings trying to get that moving pre-COVID, and obstacles being put in the way, and all those obstacles disappeared last summer when the need to recover from COVID arrived, and they literally disappeared within a week. All these things that I was being told were insurmountable disappeared within a week. So I think what COVID has done is it's really accelerated a lot of the things that we always felt we should be doing but never really got around to doing, like telephone consults, video consults, which is really important for tertiary hospitals when, you know, people previously would drive 3 hours to come for a 10-minute consultation, which could be done over the phone or video, just because we didn't have the time and the space to rearrange things. Things stalled. But what COVID has done is it's made those things a necessity. So I think while COVID, I mean, don't get me wrong, COVID has been dreadful. It's been the most appalling 2 years, 18 months you can imagine. But out of it, I think, has come real progress in several aspects of, certainly, of my practice.
Thank you, Neil. Tanis, I wonder if you can answer this one. How would you start by getting your trust to acknowledge and listen to you for the need of like a tracheostomy MDT?
I think Tanis may have frozen there, but should I chip in?
Yes, please, Brendan.
We've helped a lot of sites join the GTC in the United Kingdom and been involved in trying to persuade and provide resources for other people in other places around the world. And what we're trying to move away from is waiting for a problem to happen for a hospital organisation to say, oh, we need to sort something out, you know, we need to make a change. We're trying to get into a position where we want sites to make a change and put these improvements in place before an event happens. One of the strongest things we can do is take along someone like Alan, who can tell the hospital managers and the executives what it's like to be a patient, and perhaps where some of the problems are, and then sort of picking up on what Neil and Tanis have said, you know, taking some of those strong sort of issues to the management, but not just with a problem list, taking a list of solutions as well, and just echoing some of the things that Neil said there. If you go along with a list of things that you can do, and you've already got a plan, which the GTC lays out different strategies for making these changes. And what we've tried to learn over the last sort of 18 months and before that with our QI work is what changes we should make first, when we should do them, and then how we should do them by talking to a lot of staff. I just wondered before we close, Neil, whether we could just ask you if you've got any top tips for trying to enable change within the complex systems that we work in.
Oh my goodness, that's really tricky. Because I mean, I think persistence, when you're trying to change things in complex systems, and certainly, you know, I am fortunate enough to work at the Royal Manchester Children's Hospital, which is part of a huge NHS trust, which you also work in, Brendan, and you will appreciate that the amount of bureaucracy and complexity is absolutely huge. But I think one of the things that's really become apparent is the need for persistence on the part of people who want to make change. And the other thing I think that's really important is people respond to evidence. And what you need is, and one of the problems with COVID, of course, has been that there has been almost no evidence around. It's a novel virus, and so there wasn't much evidence. But I think as evidence appears about COVID, and as we gain evidence, I think people respond to evidence and facts rather than opinions. So that would be my main top tip. But goodness, it's been difficult.
On the subject of evidence, a lot of people want to know if there's much publication about tracheostomies not being aerosol generated in children and adults.
So I think there's some really good. I could answer that bit actually, but there's some really good anecdotal evidence coming out of some sites. Great Ormond Street have done a few. I think we could carry on talking about that we could send some further questions to you, or we could use some social media to talk about that later if people want to carry on, because I think it's a really important thing to address. But I think at the moment, I think we're going to close this panel and thank our speakers. So thanks, Alan, Brendan, Neil. Tanis has dropped out, but thanks, Tanis. And like we said, carry on your questions coming in, and we're going to continue the patient and family focused discussions in the breakout shortly. And on our next session is all about COVID-19 and the impact on trachea care. So I'd like to introduce Ganesh Suntharalingham, sorry Ganesh if I've said that wrong. He's a consultant in anaesthesia and intensive care medicine. He's the ICU clinical director at Northwick Park Hospital in London. He's also the immediate past president of the UK Intensive Care Society, and amazingly re-engineered their annual conference into ICS state of the art, whatever you want it to be. So welcome, Ganesh.
Good afternoon, I'm Ganesh. I'm an intensivist in London. I'm the former president of the Intensive Care Society. I was in office during the 2020 phase of the pandemic. It's a real privilege to be here with patient and professional colleagues on this faculty for this meeting. Michael Rosen is a friend and supporter of the Society, so it's great to see him here as well. And thank you for the invitation and for listening. I thought it'd be useful to begin with just a recap of what this virus is and how it affects us in the field of trachea care. So I'm really going to state a series of rather obvious observations and just tie them into the context, if you like. So firstly, it's a respiratory disease, a respiratory virus. That means two things. Firstly, it can spread from patient to patient, from person to person, and from patient to staff, which poses significant challenges. It can spread through droplets, which are large and fall to earth within a metre or so, or contaminate surfaces. But also it can survive in an aerosol droplet format, which can persist in the atmosphere. This is kind of relevant really to the practice of trachea care, partly because the definitions are old. They're based on epidemiology of previous healthcare worker infections in previous pandemics. And there are, I think, rightful concerns by Sarah Wallace and other speech and language therapists and other professionals in terms of how these definitions map into the provision of protective equipment for interventions such as cough assist. At the moment, the definitions of aerosol risks are really around which procedures are perceived as being risky, and that does an injustice to anyone doing procedures that aren't on that list, and really should be thinking more in terms of proximity to the airway, to the patient, duration of exposure, and the nature of what we're doing. Really too detailed a discussion for here, but just flagging up for later discussion. Secondly, as a respiratory illness, obviously it causes severe pneumonia, as we're all familiar with, and makes these patients very dependent on sometimes very prolonged respiratory care with all the airway and other rehabilitation and recovery support that requires, which obviously bears directly on trachea care as well. In addition, it's not purely respiratory. It causes multi-organ failure, both potentially through direct tropism. In other words, it has an affinity for particular tissues that carry the ACE2 receptor, but also, and probably more relevantly, through a widespread inflammatory response that causes multi-organ failure and leaves these patients very dependent on everything that we do for them. So the average length of stay of a COVID patient is about 3 times that of a non-COVID patient, and constantly they have really marked rehab needs, which are relevant to everything that everyone in this audience will recognise and be doing in their working lives. As individuals, we were certainly at the beginning of 2020, we were all naive to it in terms of our immune systems, hence the preponderance of overwhelming reactions and severe disease. And as a population, we were naive to this new virus, which meant that it spread like wildfire and still is in some ways. And as a profession, healthcare system, we were naive, and it was a new disease to us through no fault of our own. Despite all the preparation that we'd been able to do, there was a very steep learning curve for how we dealt with it, both biologically and organisationally. The infectivity is part and parcel of all this. It poses a risk to healthcare workers, risk to other patients, risk to the population. It meant all of us working in PPE, having to work very differently, and that posed quite significant human factors challenges in terms of orientation, communication, working in very unfamiliar environments sometimes, partly due to the numbers and the kind of surge pandemic way of working that we were all having to do. And also hospitals themselves had to isolate patients, cohort COVID from non-COVID patients, and essentially divide every unit in every part of the hospital into two in the hardest hit areas. And all of that posed significant challenges. In terms of scale and volume, which is part and parcel of all this, obviously there is geographic variation in this, and I'm aware obviously there's a big contingent from Australia and New Zealand who've clearly been hard hit by COVID, but the sort of large scale pandemic surge conditions may be something you haven't seen yet. But in addition to all the challenges of working with an exotic organism in a very unfamiliar way, also the sheer volume of caseload has been a significant challenge in many parts of the world. I won't go through this slide in detail because it's really a sort of mirror image of the points we've already made. But just so all of this is very relevant to trachecare. We've got the virus basically presents us with a huge burden of people with severe respiratory and multi-organ disease, big acute care and rehab needs, while also presenting us with a series of challenges in delivering the trachecare that they need, both in terms of their physiological status, the interventions we're having to do, whether it's repeat poning, high pressure, high oxygen ventilation, the hemodynamic instability, but also all the sort of soft factors around the need for a precautionary principle to protecting others, the uncertainty, the urgent need for shared agreed consensus guidance early on in the pandemic, and the kind of human factors involved in working with all this. Now, really just as a sort of concrete example, this is just a rather artificial example from one recent paper about potential spread during tracheostomy. This is a pig model, an artificial cough, forced air, and artificial dye, and really just demonstrating the droplet aspect of this, but really just a graphic illustration of the kind of challenges we're dealing with. And to be honest, the sort of fears around that, which I think are very valid. What does trachecare mean in this context? Everything from tracheostomy through to routine trachecare, through to decisions about when and where to decannulate. And for all of these, it raises big questions about timing, frequency, the right choice of technique to minimize droplet and aerosol spread, who it should be done by, whether it's with senior people, minimize the exposure to staff, but in a context where you may be diluting staff quite significantly in a surge setting. What setting? So in ICU, outside hospital, bearing in mind this involves patients who may have tracheostomies already. As an intensivist, it's tempting for me to focus on those patients coming to us with acute illness who need a tracheostomy as part of this. But actually, there are people who need trachecare out with the acute pandemic, whether they have COVID or not. And all of this raises questions of ethics and equity in terms of where we choose, when and where we choose to do things, whether we choose to do them. So early on in the pandemic, a lot of uncertainty about when it was right to perform tracheostomies, whether to treat these patients differently. Really touched on by Brendan here and others in both his paper and the diagram that he's quoting from elsewhere about the benefits of early tracheostomy in any acute respiratory illness and specifically to COVID, set against the fact these patients may be too unstable to undergo such procedures, but also the valid concerns around COVID transmission to others. And really raising that equity question of are we doing things for the patient, or are we doing things that are neutral to them but for protection of others, or even potentially adverse to them? And I think these are big questions. In that setting, what I'd really like to do is just take us back to the beginning of the kind of pandemic in the kind of Western world, as it were, Jan 2020, which sounds bizarrely recent when you look at the date, but actually is a very long time ago, and a lot's happened since then, kind of emotionally, if you like. So it feels a long time ago. The sort of preparations we're doing back then, preparing for a massive scaling up of capacity, just physical in terms of where patients would go in the hospital, and I think all of us remember, the huge amount of activity around maximising oxygen capability around the hospital, identifying areas where potential pandemic surge could go, all the physical preparations for that. Lots of discussions around equipment, including lots of blue sky thinking about using some non-healthcare engineering firms to make vast numbers of new equipment, which I think raised eyebrows for a lot of us clinically, because for us it's very much around staffing and how to look after all these patients. But anyway, it was right to think of these sort of slightly mind-boggling numbers, because nobody knew at that stage how far this was going to go. Staffing is a real issue. There was discussion of raising intensive care nursing ratios from 1 to 1, which is the normal UK number, one skilled ICU nurse, trained ICU nurse to one patient, through to 1 to 6. and through to how do we provide and care for staff using PPE and what nature that PPE should be for this new pandemic. So lots of discussion, planning, and honestly uncertainty right at the beginning. The NHS, take a UK example, went from declaring level 4 incident, which basically gave the emergency planning division total command and control over all aspects of NHS resources and policy, through to enacting that in mid-March, and everything that followed on from there. Huge multi-agency response, again using UK examples, not just the NHS, but also all the research, education, staff redeployment, Cabinet Office support, all the professional bodies, including my own at the lower right there, the audit bodies. Huge multifaceted response, and again that's common to every country, so this is all standard fare, if you like, but just to remind us of the context in which we're also discussing kind of safe trachea care. These are pictures from Bergamo in northern Italy, and I think you'll probably maybe share my recollection of looking at this and feeling a little bit unreal, thinking surely we won't be like this here, while also doing every preparation possible in case we are. Predictably enough, 3 weeks later, here we are. This is my institution again, in pretty much identical settings. All the physical preparation that went in, if you look at the peeling paint on these very old ventilators taken out of the attic, recreating whole areas for critical care that are not traditional critical care areas, repurposing anaesthetic machines, plastic sheeting for airlocks. Just going to show you this. This is outside my hospital, but this is the Excel Conference Centre. The video should settle down shortly. Just a reminder of the vast scale of potential onslaught. This is potentially a 4,000 bed intensive care unit. Clearly we never got to that stage, only a small fraction of it, and lots of things were learnt during implementing the numbers that did go here. And we probably wouldn't use that model again, but bearing in mind at the time, this was at a time we were preparing for maybe running out of intensive care beds within the month. Going back to local institutions, we all remember these sort of periods. There's a lot of theatre staff being trained for looking after intensive care patients, lots of simulation and training on intubation and PPE, discussion of staff ratios, dilution, as we mentioned. Lots of uncertainty about what that PPE would involve. Should we put people in hoods and long sleeve gloves and double gowns, despite the fact this is a respiratory illness? And that was really a human factors discussion about, will people feel safer, more confident? Will they learn to take it on and off without contaminating themselves? These sort of discussions were there early on and continue to evolve. Lots of action from professional bodies around teaching guidelines, education, standardization, and this is a point we'll return to. And really just as a reminder of where we were, these are very early discussions around triage, and would we ever get to the stage of refusing admission to patients to ITU, would normally come to ICU. Very serious discussions. We never got to that stage, and the discussions we did have are around making sure this happened in a coordinated way. So essentially we'd take the chief medical officer to come on TV and tell everyone this was happening, rather than individual sites making decisions based on local workload. And the way we escaped that scenario was really through mutual aid, transfer between hospitals, avoiding local hotspots, but also, to be honest with you, the lockdown is the key factor in terms of the numbers peaking and starting to fall. So I think a close shave, and again, a reminder of where we were, and the reminder that these sort of the context these discussions took place in. I'm going to take the liberty of just showing you a video kindly done for us by a colleague, David Knott, who works in the NHS in London, but also works for medical charities, has his own charity now, the Knott Foundation, working in war zones, and just his perspective on the mental gear shift required to move into these new scenarios. It really is a reminder of where we were back then.
When I go to a war zone or a catastrophe area, then I have to put a different head on my shoulders, one that allows me to think in a different way, one that allows me to understand the situation that I'm in, and also the resources that I have to deal with. In this situation that we find ourselves in as well, you have to be prepared to change the world around you. What you're going to do is something completely different to what your normal NHS life was like, and you're not following the normal rules. Some of the things you'll have to do are extremely difficult, and some of the decisions that you have to make will also be extremely difficult.
Thank you to David for that. I'm also, on a similar note, just going to show you a video from Jane Corbin, who's a Panorama war reporter and a reporter on other topics. Obviously, she interviewed me, so I interviewed her, and this is her insight on the same topic.
When I find myself in a war zone, covering the aftermath of a terrorist attack, dealing with a natural disaster, the first thing I tell myself is, I can do this, I can cover this, I can help these people, I know that I can do it. So determination, first of all, to do the job. Secondly, it's always a team effort, and your team around you is the most important thing of all, and you can depend on them and they will depend on you. So rely on them, bolster them, support them, and ask them if what you're all doing is the right thing. Thirdly, think out of the box. You don't have to do what you normally do. You have to use new strategies. You have to have a plan, but everybody knows that plans don't always survive their first brush with reality. So be flexible, be prepared to change, but have a plan. And then tell yourself that you can do this. You may not think that what you're doing is skillful or brave or different, but the world outside thinks differently, and that is particularly true at this moment with the NHS. And I suppose last but not least, remember your humanity.
So thank you to Jane and David. With that, I'm just going to bring us back to the context of trachea care. And just very briefly, I'm neither expert nor have the time to do a literature review of this, so this isn't about the science so much as highlighting a couple of points, really tying into those two snippets there about mindset and humanity, if you like. This paper shows a diversity of timing practice around tracheostomy care. This paper, almost by contrast, is from a single centre with a well-established, which was able to field an established tracheostomy team, multipotent, able to do percutaneous and surgical tracheostomies, make decisions based on the right thing for the patient rather than who is available to do what, operating outside the critical care team itself, therefore able to rally around. And they found, with this sort of very team-based approach, they found they could do tracheostomies early. They reported a preponderance of percutaneous tracheostomies and good outcome from early trachees. So I'm not saying that to comment on the outcomes and the science behind it, but just on the kind of team-based approach to it all. And similarly, and in parallel, a multidisciplinary team-based approach to trachea care decannulation in London centres reported here, and tying into the NATSIPS guidance from Brenda and others also reported. So really an emphasis on the human factors, the team, the systems approach, and that's mirrored by guidance from ENT UK on not just the kind of physicality and safe techniques, whether it's cautery or PPE or methodology behind tracheostomies, but also the kind of human factors and communication around planning, preparation, checking everything's in place before bringing the patient down and exposing people potentially, and mirrored also by kind of care bundles for trachea care for patients within and outside hospital, the HSN network, the patient safety collaboratives, again, we'll be hearing about later on. And the way, this is an example of how that sort of panned out. So from my institution, with thanks to my colleague Taran Tatler and his team, short interval there in the early stages of uncertainty around when it's right to do tracheostomies to people in the wider protection context, but moving rapidly on to restitution of a tracheostomy service of benefit to the patients using external guidance and internal methodology and team working. And so really I just want to bring this to a conclusion by saying COVID gave us a vastly increased need for respiratory, airway, acute care, trachea care. It posed challenges to us. Apologies, that's my coffee machine resetting in the background. I'm not going to re-record this now. It posed great challenges in terms of novelty, safety, risks, human factors involved, the scale and setting of what's involved here, and the coffee machine stopped now. Thank you. My sort of take on this overall is that we've had an evolution, really. We've had expanding knowledge of the sort of science and practice behind trachea care. We've had an evolving knowledge of human factors and team dynamics and how that pertains. And it's given us all confidence. And during that, we've also acquired confidence in our own PPE, in our own safety, our ability to protect other patients. And as a result, and this is sort of prefiguring Steve Warrillow's talk later, we've sort of identified a new normal, if you like, and the ethics and equity balance is kind of getting its way back to restoring normal practice, but in this evolving stage of the pandemic, which I think is absolutely right and appropriate. So I will stop there and hand over to the next speaker. Thank you very much for listening.
Thanks, Ganesh, and pleased to say that Ganesh will be joining us in the panel discussion in a minute. So please keep your questions coming in to Ruth. Please keep active on social media because we're going to look at everything and we've got a chance to put those questions to our speakers. I'm joined on the sofa now by Barbara Bonvento, who is the lead for our critical care physiotherapy services at Manchester University Hospital, and Sarah Wallace, who is a speech and language therapist consultant at our hospital as well. And Sarah's also the Royal College of Speech and Language Therapists advisor for critical care and for tracheostomy. Our next keynote speaker is sponsored by one of our platinum sponsors, Smiths Medical. Phil Duncan is head of patient safety programs at NHS England, and Phil was instrumental in taking the results from our Trachea QI projects before COVID and rolling them out across the country. And of course, we were helped by COVID-19, but this was in response to the COVID pandemic. Thank you, Phil.
Hello, my name's Phil Duncan. I'm head of patient safety improvement with the National Patient Safety Team in NHS England, NHS Improvement, and I'm just going to talk to you for the next 15 minutes or so about the work that our program's undertaken recently to improve safer tracheostomy care at scale. So I'm just going to briefly touch on the NHS patient safety strategy, talk a bit about the programs that we are currently leading nationally, talk about some of the emerging challenges that we clearly had as a patient safety team during the onset of the pandemic, and then go into a bit more detail around the programme ambitions, the prioritisation piece that we had to undertake, and some of the outcomes of the programme to date. So on that note, we launched the NHS Patient Safety Strategy just nearly 2 years ago now, and essentially what we were trying to do here was provide a lot more focus on looking at how we improve patient safety culture within the NHS, looking at systems to support patient safety, and broadly speaking, we poured the strategy into three main sections. One was looking at insights where we could learn more about why things went wrong, but also trying to learn from organisations where care delivered was very safe and good care. Also looking at the infrastructure that we would need to build to support patient safety, and particularly in light of continuous improvement and learning. And then the third section of the strategy really outlines the specific improvement work that we would need to undertake. So in terms of the improvement work, we currently have 5 national programs running across different specialty areas and different topics. And some of the criteria that we use to define a national program is essentially looking at the scale of a particular issue. So we would try to understand whether the scale was an issue that had significant impact on patient safety requiring national attention, rather than a localised safety issue. We'd also look at the range of interventions that are available, so really try to establish whether there are some evidence-based interventions that we could scale up nationally that are amenable to a quality improvement approach. We'd clearly look at the focus and try to understand whether there's a clearly defined patient safety issue that the challenge relates to. And equally, and just as important, is looking at timing. So really trying to establish whether there is will and readiness of the system to undertake the improvement. So these would be the kind of 4 key high-level criteria that we would use to define a program. Equally, we have a challenge in delivery locally. So we are essentially a fairly small national team across England. The majority of our delivery is via our 15 national patient safety collaboratives. These are hosted by our academic health science network. There are 15 regional or sub-regional collaboratives, each cover a population between 2 and 5 million. And really it's their role to work with systems and with clinical teams across the health service. And the key focus really is looking at taking much more of a system level approach, so groups of organisations rather than necessarily working directly with individual organisations. Their role is to test interventions, so where we have interventions that we've identified that have an evidence base, the role of the patient safety collaboratives is to test how to implement these effectively, reliably, safely and ideally sustainably. Some work where there's good evidence around interventions is around a focus on nationally adopting and supporting the spread of the interventions. But the PSCs also look at redesigning processes, look at coaching and building capability of the team, looking at how we can measure effectively, and essentially disseminating learning for others across the NHS. And we try to undertake a systematic improvement approach to all the work. So this isn't for us as a national team about commissioning the system to do this and hoping that good things will happen. We try to bring a systematic improvement approach based on a lot of the work of the Institute of Healthcare Improvement in America. And on the basis that we believe that by using this approach, we can go further and equally faster with the improvement work. So this is just an outline of the 5 national programs that we have at the moment. This is our sort of driver diagram representing those five programs. We currently have some work on maternity and neonatal safety improvements, some broad work on managing deterioration across the system and across specialties, program on medicine safety. We have our adoption spread work, which I'll just talk a bit more about in a moment, and we have a program focused on mental health safety also. So really for the tracheostomy work, that sits within our adoption and spread safety improvement program, where our ambition was to improve the care and safety of patients with tracheostomies. It's worth saying that the adoption spread program really is about scaling up evidence-based practice, and that's the primary focus of this program, where we have good evidence base of interventions that we can support with as a program to improve safety of patients. Also worth mentioning that underpinning each of these programs are a number of key enablers. So while the programs focus very much on the clinical improvement, equally there's parallel work that takes place to underpin the effectiveness of the programs. And these may be areas such as trying to look at inequalities, very much about patient and carer co-design of improvement work, an angle looking at the safety culture of teams and the organisations that we're working with, very much also about pulling individuals together through patient safety networks that we have developed. So this is part of our improvement architecture, a focus on leadership, and also a focus on measurement and building capability and capacity to be able to undertake the work. So providing the tools to frontline teams that can help with improvement. So these themes run very much across all 5 programs. So the background for us, essentially pre-COVID, was that we had already identified tracheostomies as an area to focus on. We understood that these were performed in around 10 to 13% of all level 3 ICU admissions in the UK. Clearly, the patients are often complex, across traditional specialty boundaries and locations. We'd seen to date landmark studies consistently highlighting failings in care provision. So as a national patient safety team for England, we felt there was scope for us to investigate the issues more, but also to develop a national improvement programme around this. And I think the evidence was also very overwhelming at the time in terms of positive interventions that had been employed that we could scale nationally as a national programme. So lots of the interventions were identified for us through the work undertaken by the Improving Tracheostomy Care Programme. And that work essentially was the basis on which we formed the initial principles of the programme. So some evidence-based interventions have been identified that we felt we could support the national scale up of over and above the original 20 sites that worked on the Improving Tracheostomy Care Programme. And then came the pandemic. This made us rethink our approaches, but also made us rethink our priorities. And I think at the very start of the COVID-19 pandemic, we started to see a surge in patients requiring tracheostomy as a result of critical illness from the infection. We also saw growing demand for makeshift additional ICUs to accommodate an increased number of patients. And part of our concern at this stage was that these could be staffed by healthcare workers from non-ICU locations. Equally, tracheostomy care could be provided by staff not familiar with what would be seen as normal tracheostomy care. And equally, these challenges were compounded by the uncertainties around COVID itself. So the kind of emerging new disease and what that could, and the impact that could invariably have on patients. And ultimately, I think we were also starting to see some other safety concerns across the system in terms of not only an increase in activity in some areas, but care given in unfamiliar environments, particularly those related to ergonomics of the environment and also equipment, could lead to potential safety issues. I think staff themselves working with unfamiliar staff could lead to specific safety issues, and equally where there might be variations in safety protocols and standards. So I think that probably led us to the point of looking at reprioritizing our national programs. And we basically settled on this driver diagram here. So this was an interim driver diagram where we had prioritized the improvement work that we were doing in three main areas. One was to support better management of deterioration and earlier identification of deterioration, particularly in relation to COVID-19 infections, to really focus and drive the work, building on the work that had been done to date for safer tracheostomy care in patients, and also some additional work on looking at the management of deterioration in maternity and neonates, most of which was through the use of better and more effective use of early warning scores. So this is our interim work at the start of the pandemic moving forward. And our national ambition essentially was to work with eligible sites, so acute hospitals in England that care for patients with tracheostomies, and really support the adoption of 3 evidence-based tracheostomy safety interventions. And they broadly fell into bedhead signs, availability of emergency equipment, and the daily care bundle. And we set ourselves a fairly ambitious target of trying to get to 90% of those organisations using and adopting those 3 interventions by March 2021. As an additional piece of work, we also wanted to support organisations to consider designated safe cohort wards for tracheostomized patients and ensure that the staff that were looking after the patients were trained, competently trained to care for those patients. So these were essentially the 3 interventions, as I mentioned just now. One was daily care bundle, which included 9 key elements based on the original work that was undertaken. Another was try to support the adoption of bedhead signs, where not only the type of tracheostomy was utilised, but also there was an algorithm available, to hand that individual staff could utilise should they need to. And just as important was to ensure that there was a standard set of bedside tracheostomy emergency equipment available to staff should they require it. So our broad improvement aims, certainly our global aims, were fairly consistent with other types of improvement work that we have been doing and continue to do with the programme. Some of that falls into creating safer systems of care that reflect continuous learning and improvement, ensuring that we create the conditions for a safety culture to flourish, making sure we not only focus on learning from harm, but also learn from excellence. So we utilise good learning as an example of the art that's possible, essentially. Equally supporting the reduction of avoidable harm, reducing variations in safe care delivery, and sharing improvement learning. So these are kind of the broad aims of the programme that will be fairly standard across all of our improvement work. Our specific aims for this programme were to support the implementation of the key 3 interventions that I just mentioned, but also to try to rapidly develop the skills and knowledge for bedside staff to deliver safe care in all environments. And our delivery mechanisms were through our patient safety collaboratives. So remembering there are 15 of the collaboratives that are cover the whole of England. Really, their delivery mechanism was to collaborate nationally, so utilising the national ambition that we had set ourselves as a driver for change. Part of their role was to create and develop networks of individuals coming together to try to support engagement, particularly with senior leaders, as to the case and reason why this is such an important piece of work, and certainly at this moment in time. They provided direct support and coaching and capability building around quality improvement approaches and tools that could be used to accelerate the pace of change. They provided access to a number of resources that had already been developed, but equally developing resources as we learned through a program. They would provide support with testing, program management support, and also support with measurement. So there's a whole package of support across our 15 collaboratives and engage the country in this really important piece of work. And there were also many resources that were developed as part of the learning, as I've just said. So here's just some examples of some additional resources that were developed by patient safety collaboratives, our national team, and indeed our colleagues working in this field that are readily available today. And our outcomes were that we achieved 92% of hospital sites having adopted all 3 tracheostomy interventions, which I think is remarkable given that the scale of the challenge and the speed at which this was done. We reached bedhead signs to 94% adoption, emergency equipment reached 100%, and delivery of a daily care bundle reached 97% of adoption. And it's probably worth mentioning that these case studies are continuing to demonstrate an increasing spread and sustainability of the interventions since March 21, which is fantastic news. And just one case study from one PSC here, which really kind of demonstrates the nature of collaboration, of a collaborative approach, of shared learning, and the opportunity to develop useful resources for clinical teams doing this work. So the PSCs really had a key role in facilitating, coordinating that type of activity that brings people together around a common issue and a common challenge. And in terms of the future for us is that we generally want to learn more about the success of this work, but equally to see how much impact the work has actually had. So we are currently scoping a mixed methods evaluation, looking at patient outcomes in terms of time to talk, patient experience, looking at the impact on healthcare services in terms of ICU length of stay, hospital bed days, and also looking at whether or not there have been any direct or indirect efficiency savings in terms of finance. So our evaluation is likely to include a quantitative analysis using hospital and audit data sets and a qualitative review to understand patient and clinical experience. And we're hoping to start that piece of work probably in the autumn of this year. Thank you for listening.
Well, thank you, Phil. That's an amazing feat to deliver that project during the pandemic. Now, as a respiratory physiotherapist, I have the honor and the privilege to follow patients from their admission to intensive care until their discharge, to see them walk again, to take the few steps, to cough by themselves, to breathe by themselves. It always remind me why I chosen this profession. One of these patients was brave Dr. Anusha Gupta, who is a GP from South Manchester and mother to gorgeous Ariana. Now we're going to listen to her experience. To you, Dr. Gupta.
Hello, my name is Andrew Bentley. I'm a consultant in intensive care and respiratory medicine at Manchester Foundation Trust at Wythenshawe. I run the long-term ventilation service for patients who are in chronic respiratory failure and have a specific interest in weaning from prolonged mechanical ventilation.
So hi, I'm Sarah Wallace and I'm consultant speech and language therapist at Wythenshawe Hospital, which is a Manchester University Foundation Trust. And I work in critical care and with the ventilated patients, and I look after our service to ventilated patients and carry out research as well into communication and swallowing problems.
My name is Anusha Gupta and I was a patient during the COVID pandemic. during the first wave in March 2020 at Wythenshawe Hospital, and I'm here to say my story.
My name is Barbara Bonvento. I'm a clinical lead physiotherapist in acute intensive care at MFT, Wythenshawe Hospital. I look after ventilated patients. I'm interested in tracheostomy and rehabilitate patients as well.
Hi, my name is Ian Monsang. I'm a senior specialist nurse on the Northwest Ventilation Unit at Wythenshawe Hospital. We do deal predominantly with non-invasive ventilation patients, but we also work alongside a specialist team who provide the continuing support for long-term ventilation weaning patients as well.
So I'm a GP in South Manchester, and I became unwell with COVID during the first wave of the pandemic back in March 2020. And it started off with becoming quite short of breath, which progressively got worse. And that's when I was admitted into Wythenshawe Hospital on the 1st of April. Once I was admitted 4 days into my admission, I deteriorated further. And that's when it was decided by the team that I would have to be ventilated. I do remember being admitted to the ICU. I came down from the respiratory ward to ICU when I was told that I would need to be ventilated. And I just remember there was a big entourage of doctors and nurses that came up to get me from the ward. I came down to ICU, and then the only thing I remember at that point was that I had a mask put over me and I fell asleep, and that was it. And then I woke up when I did. And then it wasn't immediate that I realized that I had a trachea. Initially, when I woke up, I was quite confused. Yeah. So when I woke up in the cardiac ICU, I was actually quite confused. I had these visions of almost like being in a cage. I felt like I was in a cage. And I think I remember the initial memories being, where are my parents? I actually forgot that I had a child and a husband, which was a bit odd. When I think about it. But yes, I remember trying to ask the nurses how my mom and dad were, but I didn't mention my 18-month-old baby or my husband. And it was only probably about 2 weeks later that some of the nurses started to prompt me that, you know, your husband's been asking after you, your little one's been asking after you. And that's when it slowly returned. But I was quite confused initially. So when I woke up, I didn't actually realize that I had a tracheostomy, which is a bit odd. And yes, soon enough, I realized that I couldn't speak or there was no sound. And that was really frustrating initially because I felt like I couldn't communicate. I felt locked in almost. There were many nurses that could lip read and many that couldn't. And it just made it quite difficult communicating. And it was quite scary that I didn't have any voice. I couldn't use my arms or legs. I couldn't lift my arm up. I barely had like a wavery movement of my fingers. So that all the more scared me, actually, even though I'm a medic and you wake up, you just don't think about these things when you wake up. And I woke up and realized that I had no use of my limbs. I couldn't speak and I literally felt like a vegetable.
Do you remember when you first got a voice?
Yeah, I vaguely do remember. It was like a little whisper. Even now I'm told that my voice sound is probably not as loud as it normally would be, but I remember when I first got my voice, it was like a whisper. Yeah.
We actually did a technique called above cuff vocalization with you, which was to blow some air through from just attaching it to a bit of oxygen, because your cuff on your trachea tube was inflated, which is why you didn't have a voice. So we wanted to blow some air artificially through your voice box, and you did get a bit of a whisper voice.
Yeah.
So we use that technique as an early way of trying to facilitate you to get your voice going.
Yes.
As well. So it did work a little bit.
Yeah.
We'd actually tried that a few times.
Yes.
Until we could get your cuff down.
Yes. The whole sensation of being on the ventilator was very odd, actually. Especially when the machine is working and I'm also trying to breathe. I actually felt very breathless. I do remember feeling breathless because I've kind of played back some of the messages that I may have sent to some of my friends. and I sound extremely breathless, and I can hear the ventilator working in the background as well on the recording. So yeah, it was a very odd experience.
During that sort of weaning process, we dropped the help from the ventilator, made you work a bit harder. How did you remember how you felt during those times where we were trying to make you work a bit harder?
I remember having many conversations with Prof. Bentley about this, and I was very worried about it, you know, when that was going to happen. In fact, I was worried throughout the majority of my admission. But with regards to the weaning, I remember asking you, you know, how would I feel? Is it going to be painful? Am I going to get extremely breathless? So I remember Prof. Bentley saying that, you know, it's called a sprint for a reason. So I remember those words. And so, you know, I remember he would explain to me that, you know, you would feel like you are running. So I thought, okay, I think I can probably cope with this. And I remember telling the nurses that don't tell me when you are going to drop the support. So, yeah.
Did you ever feel in those first sort of days, Anu, that you weren't ever going to get off a ventilator, that you were stuck?
Oh, many times.
Yeah.
And I can't remember, there are a few nurses who would often joke about it and say, look, Anu, we can't let you go home with the ventilator. Yeah. So, you know, you will come off this. And I remember there were many times when I had conversations with the nurses and some of the consultants, very upset emotionally and drained and thinking, will I ever get home? Those were the main questions I used to ask. You know, will I ever actually get home to my baby, to my husband? You know, will I ever get to see her? Because obviously at that point it was late June, July, in ICU, and I hadn't seen her since the back end of March, and it was really traumatic. So yeah, many times I was worried I would never get home.
Thank you, Anu, for sharing such valuable insights into your very difficult journey to recovery. So please keep your questions coming in for Ruth and for the panel at the end of this session. Next up, we're going to hear the healthcare perspective on the long wean and how the Northwest Ventilation Unit helps us. We're very lucky at Wythenshawe Hospital to have this ventilation service. And what we're going to hear about is truly multidisciplinary care involving respiratory physicians, physio, speech and language, specialist nurses and many others. And how we work together to help patients like Anu recover and get back home.
So when I first see a patient, I think it's important to actually go back over the history and undertake a clinical assessment. There's no substitute for knowing actually the sequence of events, the duration of the ventilation period, and the clinical assessment in terms of identifying severity of weakness, their underlying comorbidities, and actually any medications and interventions that they've had that may contribute to intensive care or critical illness weakness. Notably, I'm thinking about high-dose steroid medication, the use of neuromuscular blockade, etc. So that helps us to give an understanding of where we actually are, and with understanding of the comorbidities, you can then do a systematic approach in terms of, and I divide it really into an A, B, C, D in terms of not necessarily in terms of priority, but considering is there anything around the airway that needs optimization? Have they got the right sort of tracheostomy in place? Are there any issues around secretion management or secretion clearance that can be optimized? Do they have underlying airways disease, for example, that may need some medication and bronchodilator therapy that may need to be helped? What's the state of their cardiovascular function? Do they have underlying left ventricular dysfunction, or equally, do they have some right heart failure and associated pulmonary hypertension that may need optimizing? Clearly, with associated intensive care weakness moving down in the organ systems, from there, nutrition is absolutely crucial, because clearly they've been through a very catabolic state, and we have to make sure that they have adequate nutrition. So that's absolutely crucial. and clearly underlying endocrine and metabolic states, which actually helps particularly to actually identify the state for when they actually want to start, when we want to actually start weaning. Because when often a patient is referred to me because the patient has failed to wean or failed to be liberated from a ventilator, more specifically on previous attempts, quite often it's the fact that they're not actually ready to wean at that time, and these other areas that I've just highlighted need to be optimized before we start the process. My first priority in that is to try and optimize the respiratory function as much as possible, and I tend to focus on trying to control hypercapnia, because hypercapnia itself can be a predictor of failure to wean. We haven't worried so much about hypercapnia in the initial management during the acute illness of the patient, but it is important to consider during the actual weaning process. So I will try and achieve the appropriate settings on the ventilator to achieve a good control of the PCO2. Ideally, if it's feasible, less than 6.5 kilopascals would be the target that we'd use. And then I would define that as a rest setting. We'll use the other criteria, such as the amount of oxygen the patients require in the FiO2. Clearly, they would need to be ideally on less than 40% oxygen before we would start the weaning process, as you would in terms of trying to liberate anybody from a ventilator, for example. When it comes to the actual mode of ventilation, I think this is less crucial. If you look through the evidence base in weaning, it's how you do it, not necessarily what mode you're actually using. It's the strategy that's you can adopt. I tend to use an assist control mode of ventilation on a ventilator that will actually tolerate leaks, so that we can facilitate periods cuff down, I'm sure, which we'll come on to. But actually, whether you use a pressure support mode, a pressure control mode, a volume assured mode, it's really the consistency with the individual approach that you're doing which is important, rather than actually switching between modes and any one mode better than the other.
From your perspective, Yaman, what do you think's more important, the weaning strategy or consistency?
Partly both, really, I think. I think obviously the strategy is important to be able to know where we are going to with the weaning plan, to have a plan laid out in front of us. But you can't really follow it rigidly. You have to always understand how the patient is, their patient's comfort, and how tired they are. So consistency is also important as well with regards to weaning. So it may be that you get part of the weaning plan done in the morning, your patient might be feeling too tired for the rest of the afternoon, so then you might take a step back and then continue with that weaning plan the following day. So it's we don't necessarily rigidly follow the weaning plan.
Anu, from your perspective, did you understand what the sort of weaning plan was and what we were trying to achieve?
Yeah, I would say so. I mean, it was quite daunting coming, just being told that the support is going to be reduced, but I was reassured by, Prof. Bentley and his whole team and everyone in ICU that it's going to be done very cautiously and very slowly, initially starting off with very short bursts where the support will be reduced and then gradually increased. And I just thought the only way that I would probably get my head around this is if I didn't know that it was happening. So I just told the nurses that please don't tell me when you are going to drop it. And that happened for majority of the wean. I do remember that I wouldn't even realise that it has actually been dropped, and I would be told later by the staff that you did all right and you seemed fine. It was just as the wean times were gradually increased. So, for example, if you're on it like 8 hours of the day on a sprint, then you kind of clock on already that I must be on a sprint, 8 hours of the day. And I don't know, maybe knowing made it worse sometimes, knowing that you are on a sprint. And then doing a sprint whilst you're having to do physio made it a little bit more challenging, but I think it got better, obviously, and it was all done very, very slowly and gradually. And I do remember, because I would often pester some of the consultants for the actual the strategy plan, because I was interested to see that, you know, how we are going to progress. And obviously, like you've explained, that, you know, we won't always stick to that plan. It depends on how I'm responding. And yes, I think there was some days where we couldn't stick to the plan because of how tired I may have been that day. But I was so adamant to come off the ventilator. So I was interested to know how many days more have I got, and I would often calculate in my head, right? I think if we stick to this plan as we are going, providing there's no glitches, I should be off it by X day. I think as the sprint times got longer, it just felt a little bit harder. Just like you said, you know, it just felt like I was doing a run. I don't think I ever felt anything worse than that, to be honest. Personally speaking, I don't think I felt anything worse than that, other than tiredness and breathlessness at the time, just mild.
How do you fit your physio plans around a wean?
So at the initial stages of the weaning, the sprinting, we tend to tailor around that. So we would avoid to do physiotherapy when they are in the initial stages. Obviously, before we see a patient, we take in account of the vital signs and the gases, and according to them, we proceed whether we treat the patient or not. We obviously clear, you know, do chest clearance. We do with Sarah as well, cough down treatment. So it's like very much of a team effort, but we try to see if the patient is agreeing with that first of all. Sometimes, you know, when the patient feels tired, if we know that it is scary for the patient to do something when they feel breathless, but we try to encourage them to do something with those, but obviously not to the initial stages of the sprinting. We would wait for that to finish the initial sprint, and then we proceed with physiotherapy.
I think there was a period, Brendan, actually, in terms of having to pace the weaning because of the situation you were describing. In that situation, some days we wouldn't progress perhaps quite as fast as we'd initially thought. But actually, that's not necessarily a bad thing, because as long as, you know, the next day or the day after, we can actually continue to move forward. So we have to actually react to how you are feeling as well as actually doing at that time.
We talk about protocolized weaning sometimes. What's your approach then when you're trying to make a plan for a week or 2 weeks? You know, how much of the time do you have to change that plan?
I think quite frequently. I think actually it's a plan in the broadest sense, in terms of trying to achieve some basic principles, in terms of trying to have some periods where we are actually sprint weaning. And we say we may develop this over a few days, achieve it over a few days. And we know that some days we may be able to succeed and others we don't. And the thing to do is not to try and necessarily achieve the endpoint by a certain specific number of days, because you may actually precipitate a failure. And then it may set you back even further. So actually, if you haven't been able to achieve something one day, you don't push it on to the next phase of the wean. You actually repeat what you did the previous day until you're able to succeed before you move forward. And patients will progress at different stages for various reasons that we can come on to.
Could I ask you, Sarah, what is specifically your role in helping patients move forwards with their wean?
So our role covers quite a few different things, really, but one of the really important things that we can do early on is detect if there are any problems with the upper airway, which may then delay weaning or prevent you getting a voice, or even struggling with your swallowing. So I don't know if you remember, Anu, but you actually had some swelling in your voice box and your larynx. That's actually really common, and it can occur because you've had tubes down. It can occur with COVID itself as well. So one of the things that we can do is really work out, are there any problems with the upper airway which might lead to complications? And we actually had a look at your larynx, didn't we, with a scope? Can you remember that?
On CTCC first.
Yeah. So often when this happens, it means that you become very numb in your throat, you stop swallowing, your muscles get weaker, and secretions and saliva builds up there as well. So we're really concerned with trying to solve that problem of how to get someone swallowing their saliva. You have to be able to do that before you can eat and drink.
Yeah.
But facilitating you talking and eating and drinking as soon as possible. And there's lots of strategies we can use to sort of really help you to manage those problems with upper airway secretions, to really sort of support you to get your voice back and get you eating and drinking as soon as possible, because there are obviously complications if we let you eat and drink and things are going down the wrong way. That can lead to chest infections, which will actually delay the weaning off the ventilator. So we've got to prevent those complications, haven't we? But also acknowledge that you're thirsty, you desperately want to drink. That affects your nutrition and your mood, and how so we've got therapy techniques we can use, and strategies like using speaking valves, one-way valves, which getting the cuff down on the tracheostomy, which blows air through the voice box to stimulate you to swallow and stimulate your vocal cords to work. Your vocal cords weren't working well at all. Do you remember one of your vocal cords in particular didn't really move?
Yeah.
Do you remember the pictures of that when you looked?
I just remember it was very inflamed and swollen.
Yeah. We actually gave you some steroids as well, and we actually gave you some medications to dry your saliva secretions as well, just so that we could push you forward with the wean and get your cuff down sooner. So there's certainly things that you can do to really not just sit back and wait for things to get better, but actually really rehabilitate your larynx. And you were brilliant at doing your swallowing exercises religiously and really trying to strengthen those muscles. So yeah.
So you mentioned speech and swallow valves there. What do they bring to the weaning process?
The one-way valves are an invaluable part of I think the weaning process, because what they actually do is push all of the air through your vocal cords when you breathe out, and that means that we're stimulating the vocal cords to close, and that's important for coughing, which is why we often do assessments together, isn't it? And it's important for your voice, so that you can talk to people and communicate and engage in your rehabilitation and engage in whole weaning decisions. And I think it helps your anxiety, doesn't it? And it can really help to push those secretions out of your larynx, so that they don't go down the wrong way so much, so you can protect your chest and stimulate the sensation, because you were initially almost completely numb in your throat, so you didn't feel what was happening. But later on you became really oversensitive. And again, it can kind of just help to balance that sensation and bring it back to normal. And obviously, normally we breathe out through our upper airway, but with a tracheostomy, it becomes a little bit abnormal. So the valve restores that normal physiology and helps you to cough, swallow, even sort of brace yourself for sitting balance, and even sort of when you go into the loo as well, that push that you get when you get vocal cords coming together. So a whole range of benefits.
And Annie, do you remember much about eating and drinking when you had the tracheostomy? Because I guess to start with, you probably wouldn't have been able to eat and drink. Did you remember those first tastes of, I'll say food, but it may well have been slop?
Well, when I first woke up from sedation, the only thing that I could have was those lolly sticks, and it was really hot. It was around, if I recall, it was around June time, and it was so hot on the ward, and I just was desperate to have a drink of water, and it was deemed that it wasn't safe, obviously, and the only thing that I could have was these lolly sticks soaked in a bit of water, and that I had to make do with for quite some time. It was a good few weeks.
It was,
and then it was. I remember Sarah and her team did a fees test up on CTCCU, and then I was really hoping that she would say, yes, I think you're safe to have some water, but no.
So yeah, sometimes patients have to be nil by mouth because the swallow is unsafe, and obviously as patients get more awake and recovering, they're desperate to eat pie chips and get back to normal. How do you cope with patients who want to walk before they can run when it comes to eating and drinking?
It's really difficult, just like you said, like your patients, if they know by mouth and they're not allowed to have anything, you do feel desperate for them, that, you know, they're asking for a little sip of water or you know, something on their tongue and that, and it's just something impossible that you can't do because you know it's not safe. So the only things that you can provide is, you know, like you said, Anna, it's just little sponges to wet the mouth and just making sure that you're providing, you know, good regular mouth care all the time. It's very hard, and it's a hard thing to do. I mean, there are other things that you can provide to keep the mouth moist, you know, like oral gel or fake saliva. But a lot of the times, patients don't really like that on their mouths. It's not. Have you tried it before? Yeah.
I think with these things is one of the things that we're trying to do all the time is weigh all the risks versus the benefits. And you know, there's huge benefits to obviously allowing someone to drink again. It's a big morale boost. It's quenching thirst, and but we're weighing the risks of someone who's had really bad lung infections and trying to get off a ventilator. So often we'll start with therapeutic tastes, what we call just having little bits of something while you do your swallowing exercises to really try to optimize your swallow before we go all out for a whole drink, don't we? You went through that gradual phase of having a few little bits of something. So it's just balancing those risks and benefits, and I think explaining and using things like images to really help you understand why, and also what we're going to do about it and what we're going to do next, so that you don't feel like you just know around forever.
So we've got a selection from the tracheostomy multidisciplinary team here, and I know there's obviously lots of different people involved in your recovery. Who are the different people, different job roles that you remember contributing to your recovery?
So obviously when I was in ICU, so all the doctors, all the medical staff, the nurses, the speech and language therapy team, physiotherapists, and obviously that all continued when I went onto the long-term ventilation unit. Over there, obviously I had further input from occupational therapists, so, you know, getting me ready to get home, so becoming more independent, being able to wash myself and self-care, brush my teeth, you know, the sort of basic sort of things, you know, and then things that I could have in the house just to help me, like aid my mobility or getting up and down, etc., that sort of thing. So these sort of aspects had to be assessed before discharge. And then of course, my dietitians in ICU and also in long-term vent, looking at, you know, what my intake was and how that could be improved. And of course, you know, psychology input, that was so important, which I got when I was in the Northwest Ventilation Unit, and how you actually said that it also carried on when I was, you know, when I was discharged for a few months thereafter.
The weaning process continues.
Thank you, Anu. That was lovely. And it's really good to reflect how we work together as an MDT. I think we can all agree to that, don't we? We gel quite well together. So my next job is to introduce you to Dr. Stephen Warrilow, who's got a lot of credentials. So he's the Director of Intensive Care at Austin Health, and also the Director of Critical Care Institute at Epworth Healthcare, and the immediate past president of the Australian and New Zealand Intensive Care Society. He also convened the World Congress of Intensive Care in 2019 in Melbourne, which was amazing. We all attended, and we still want to thank you about that. So, Dr. Warrilow, to you.
Hello from Melbourne. It's lovely to join you again. My name is Stephen Morello, and despite being locked down and on call, I think I can get 10 minutes of uninterrupted time to share some insights with you regarding the role of tracheostomy in these challenging COVID times. In terms of my interests, I'm the Director of Intensive Care at Austin Health in Melbourne, and I've got affiliations with the University of Melbourne and the Australian and New Zealand Intensive Care Society. I would also like to acknowledge that I live and work on the traditional lands of the Wurundjeri Willam people of the Kulin Nation, and I pay my respects to their elders past, present and emerging. It's fair to say that those of us who've chosen to work in critical care are used to hard work and various challenges. Nonetheless, there's been something else hanging around in the last 18 months that's been rather unsettling. Until a short time ago, this guy, SARS-CoV-2, was entirely unheard of, certainly in clinical practice, and even the SARS viruses were really the domain of epidemiologists, virologists, and maybe veterinarians, certainly not really clinicians, except for a couple of unfortunate encounters back in the early 2000s, which we'll touch on later. The implications of COVID on ICU practice have been vast, but for COVID-affected ventilated patients, it's not just the absolute numbers that have proven challenging, but also the number of bed days that they occupy. Many require several weeks of mechanical ventilation, plenty of time for them to acquire various complications and develop a full-blown ICU-type syndrome of deconditioning and potentially multiple organ failure, but also impacts on our ability to care for other patients, including non-COVID affected. It seems ultimately likely that, as for so many of our other long-term ICU patients who need perhaps a slow win for mechanical ventilation, that COVID-affected patients in a similar situation are likely to benefit from a tracheostomy. And there's no specific patient-centered reason really to alter our usual process of selection or clinical decision-making. The impact of COVID for clinicians caring for COVID patients, however, is quite profound and presents a new, jarring and very challenging scenario. Firstly, there's an understandable, powerful fear of droplet and airborne transmission. This has really important safety considerations for our healthcare workers, as well as having an impact on issues such as furlough and service provision and ability to care for other patients. And it has meant that we've had to take on a complex reconsideration of balancing patient-centered care with essential requirements to protect our teams. This influences considerations such as the timing for tracheostomy and lets us rerun the early versus late debate. Also, the approach to tracheostomy itself. Is there a role for maybe preferring a surgical approach versus percutaneous? As well as the location. Does it happen in the ICU at the bedside, or do we move back to the operating room? And also, what precautions are really necessary? Is an N95 mask with full PPE acceptable, or do we need to move to more sophisticated, complex, and indeed costly approaches, such as portable air purifying devices? And ultimately, what is the right balance and who is at risk? For patients, we pretty much accept that prolonged translaryngeal intubation is associated with potentially preventable complications. So going too late isn't really ideal for the patient. That said, for our staff, the inadvertent and maybe avoidable exposure to droplets and aerosol generating procedures and exposing them to the risk of acquiring COVID and becoming ill or being furloughed has a profound psychological impact. And in addition, they'll also be worried about taking it home to their family. So where can we seek guidance on these complex issues during trying times? Well, at least initially, we're kind of forced to seek expert opinion and evidence-based recommendations from experienced clinicians and august societies and colleges. These initial recommendations were appropriately, indeed necessarily, very conservative and had an extremely strong focus on protecting healthcare workers. The reasons are perhaps obvious, but bear repeating. SARS-CoV-2 was a novel pathogen. Its true virulence was unclear, and there was great uncertainty as to how transmissible it really was. There was a strong obligation to protect the clinical team, because ultimately, no team equals no patient care for anyone, including those affected by COVID. These concerns were not ill-founded or made up. If we reflect back to 2003 with the very serious outbreak of a related virus, SARS, a number of healthcare workers lost their lives. And I've provided an extract of those affected there, but it included medical staff, nursing staff, techs, other healthcare workers, including paramedics. That had a profound impact on those systems, which resonates to this day. Common elements of these early recommendations were an emphasis on avoiding aerosol generating procedures. For example, therapies such as high flow oxygen therapy in intubated patients, the use of non-invasive ventilation such as CPAP or BiPAP was frowned upon. And it was suggested that we should really intubate very early and maybe bypass these kinds of interventions. In terms of the use of tracheostomy, some recommended avoiding it completely, or at least delaying it until perhaps the patient was no longer infectious. It was also suggested that perhaps it would be safer to do it in the operating room and the intensive care bedside approach should be avoided, and that maybe it would be safer to use a surgical technique and best to avoid a percutaneous approach. However, such planning can make a lot of sense at the time, but not necessarily survive the reality of encountering the enemy, as was understood by Helmut von Moltke, a Prussian military commander, and perhaps put a little more succinctly by Mike Tyson in his famous phrase, "Everyone has a plan until they get punched in the mouth." So what have we learned? Well, there's been some really important discoveries on this journey. Firstly, and quite reassuringly, it turns out that personal protection equipment is really quite effective. I think many of my staff would agree that they feel safer at the bedside in the COVID pod than they do at the tea room. Also, as it turns out that maybe the issue of aerosols and airborne transmission, whilst real, can nonetheless be managed in the highly controlled critical care environment. And finally, an emerging realisation that patients may actually be harmed if clinical decision-making is distorted, or that we avoid good normal practices, and evidence-based therapies are withheld, such as the use of non-invasive therapy for COPD or heart failure patients, due to an unreasonable or extreme focus on risk. And helpfully, we've had a number of studies starting to come through, including this one performed by the Queen Elizabeth Hospital in Birmingham, which have actually documented their approach to safe tracheostomy management in this particular patient population. Let's look briefly at what this team from Birmingham found. Theirs was a prospective observational study of 100 patients who underwent tracheostomy. Now, of course, it has some potential for selection bias and some other limitations, but nonetheless, a very useful addition to our knowledge base. They incorporated a particularly specialised team who performed 90% of all of the tracheostomies, which were mostly percutaneous and in the operating room. They did not have explicit criteria for tracheostomy, but really just a consensus of clinical decision-making by experienced specialists. And they had no particular consideration for checking for patient infectiousness at the time of tracheostomy. It's also worth noting that they had quite a high utilisation of tracheostomy in their patient cohort at 61%, which is give or take about 4 times as has been reported in other case cohorts. Most notably and reassuringly, however, there was no instances of transmission to staff, although to be fair, there might have been some limitations with the testing regime used. They also indicate that there may have been a 30-day survival benefit and a reduced length of stay if done within 2 weeks. So how does living and working with COVID-affected patients for 18 months and the published experience of groups such as that from Birmingham influence our current thinking? Well, in terms of patient selection, it's kind of similar to what we normally do. The patients need to be improving and not in the hot phase of their critical illness. And certainly it's not helpful to put a tracheostomy in patients who might be actually dying. In terms of the timing of tracheostomy, I think we've now shifted back to doing it a little earlier. And it's far more consistent with our business as usual approach, perhaps. And maybe as it turns out, while the risk of aerosol generating procedures is clearly real, maybe it's actually a little less than we previously considered. Although I guess we need to be a little bit cautious on that front in terms of the potentially increased infectiousness of emerging variants. With regard to technique, I think we're increasingly suggesting do whatever your unit does best. Both surgical approaches and percutaneous approaches may be made safer through modest changes in techniques, such as pausing positive pressure ventilation at key moments during the procedure. But really, I would suggest do what you do best and stick with it. In terms of the location, I think both the operating room and the bedside can be made safe. There's pros and cons with both. In terms of aftercare, the approach should strongly resemble the care that we provide to any patient with a tracheostomy, regardless of COVID status. The best approach is likely to be multidisciplinary and team-based, incorporate people with particular skills who are well trained and educated in tracheostomy management. We should be proactive in monitoring and watching for complications and have an approach that emphasises early escalation of concerns to highly trained relevant experts. So in reflecting on our current recommendations, whilst it's true that COVID-19 has produced an immense shock to the system, there is a slow but welcome transition from eminence-based recommendations, which were very, very conservative early on, to hopefully what might be evidence-based practice for tracheostomy decision-making and care. It's increasingly clear that tracheostomy will have an important role for some patients with COVID, and that a business-as-usual approach is probably the right one. Just make sure the PPE is utilised very well. Now, there's still more to learn about the impact of new COVID variants, patient selection and timing of tracheostomy, but many of those considerations apply to our general patient population anyway.
Thank you, Steve. It's fascinating to hear you talk about your experiences during this pandemic. So I'm delighted now we're joined by Steve and Ganesh, and we've got a very high-profile panel where we've got both immediate past presidents of their respective countries' intensive care society. So welcome. Please keep your questions coming in for this panel discussion, and I'm going to hand over to Ruth to see what's been coming in.
Firstly, I just want to say that the slides will be shared on the platform. Sorry that some of them were a bit blurry, but we are going to share them so they'll be available for everyone later. And thank you to Anu. Everyone appreciates you sharing your story. So thank you, Anu. So first one's for Ganesh. Ganesh, how did the transition from surgical to percutaneous tracheostomies occur, and what kind of happened for you to decide to do that?
So in our centre, we were fortunate to have a kind of very active ENT department. So I think it's probably fair to say we've remained largely surgical. But as Stephen pointed out in the Birmingham paper, it is interesting when you've got a dedicated team able to do both and sort of decide the location and technique based on what's best for the patient rather than which team or which set of expertise is available. Here in the UK, the percutaneous tend to be done by intensivists on site, and then if we have it done surgically, it's done by the ENT team in theatre. So the Birmingham study is interesting, or the Birmingham series is interesting in that context, because if you're neutral to that, the decisions they then made are I think interesting that they've the predominance of percutaneous.
Lovely, thanks Ganesh. And Stephen, one for you. I know things are unfortunately escalating in Australia at the moment, and you guys have gone into lockdown. Sorry to hear that. Are you guys kind of continuing as business per usual? Have you kind of reverted back? How are things in Australia at the moment?
We're enjoying a taste of what you enjoyed in the Northern Hemisphere some time ago, unfortunately. Cases are rising exponentially here, and we're busier than we've ever been. So in a sense, we're very grateful for the experience that has been shared by our colleagues, particularly in the UK, but also North America and other parts of Europe. It's been very helpful in assisting our preparation. At the same time, I think we'd all acknowledge that COVID is a sort of a tango between the virus and the human response to it, and the Australian response has been mixed and varied as well. And our approach to tracheostomy is very much now a business as usual model. We'd previously had a hyper-conservative approach. I don't think we were Robinson Crusoe in that regard. That was pretty common, as I outlined earlier. Now the timing, the technique and the overall approach is very much swung back to being wholly patient-centred, really, with appropriate PPE, rather than maybe what might be an excessive concern for staff wellbeing. Not to say staff wellbeing doesn't matter. I think rule 1 of our approach to the pandemic management has been protect your staff, and rule 2 is refer to rule 1.
Oh, thank you, Steve, for that. Barbara, I think I know the answer to this question. Motivating people, you know, physiotherapy and rehabilitation can be really difficult. But how do you and your team motivate our patients on the unit?
It is quite difficult. It is an art in itself. Well, there is a song for every action that we do in intensive care, for every movement. We tend to, you know, play music to the patient and to make things a bit less stiff and less kind of regimented. So we include like, I don't know, dancing and football. We ask what the patient likes to do. We ask sometimes when the patient is still quite sleepy and not really engaging with those, we ask what kind of music the patient likes. So we play the music that they like and so on. But it is quite challenging, I have to say.
And when you get them singing, that's really helpful for their voice as well.
We sing together, but they don't want to listen to my singing sometimes. So they say, well, if you don't do it, I'm going to carry on singing. So, you know.
Sarah, we've had loads of interest in above cuff vocalization, and a lot of people are saying that they'd love to implement it on their units. Does our trust have any facilities about training people up to do fees or anything?
Fees, or we talk about ACV?
Oh, sorry, this is skipped. So 2 questions.
Okay.
About the above cuff vocalization one. Is there any relation to surgical emphysema? A lot of doctors seem to be reluctant to use it on their unit because of that. Can you tell us more about that?
Yeah, sure. So that is a recognised concern, because you obviously need to have a patent upper airway if you're going to blow airflow artificially through the subglottic port. So it's this technique where you use the subglottic port, which is normally used for removal of secretions, to blow air in, and then you can facilitate airflow through the vocal cords, even when the cuff's inflated and the patient's, you know, cuff inflated on the ventilator. So if your upper airway isn't patent, if you've got any edema or vocal cord issues or secretions blocking that, then the air's got nowhere to go and it can't escape out the upper airway, and it can go into the soft tissues, and you get a very dangerous situation with swelling. So it is a concern. It does happen, and that's why we always say that you should have very low flow and you should observe your patient and supervise your patient if you're actually doing ACV. And I think it's important that you have people who understand the technique, and that, you know, I would advocate for speech and language therapists to actually have a little look at the patient first and do an assessment of the safety of ACV before you actually just plow on and you know, go for it.
And do we have any guidance for kind of above cuff vocalization that we can share? A lot of people are interested in looking at some guidance.
Yeah, well, there's nothing official, but there is some guidance that we've developed that we can share. I think, is it on the NTSP website, Brendan? Yeah. So if you go to www.tracheostomy.org.uk, it is there, and that's our protocol, and it explains all the evidence base and the technique itself and how to go about it in the safest way possible. But it is currently a very cobbled together kind of technique, and Brendan and I are doing some really exciting research actually in this area and looking at how we can refine it and work out safer ways of detecting things like obstructions to the airway and you know, a sort of slightly more robust method.
It's probably worth highlighting, sorry to interrupt you, in Stephen's Hospital, the TRAMS service have got an awful lot of resources as well, haven't they, Steve, for lots of things to do with tracheostomies.
Correct, and it's all available online. So if you Google it, it's not hard to find, and yeah, we're delighted when people use those resources. So yeah, please look them up.
Cool. Sorry, so many questions coming in. This is really, really good. Again, Sarah, in patients who don't tolerate cough down, would you use above cuff vocalization to get them talking and communicating early?
Definitely, but obviously there are lots of different communication strategies that the whole team can use. Often it's something very simple, like having you know, the right charts available, or you know, everyone can facilitate communication. So it's ACV is one technique, and it doesn't always work, but it can facilitate some whisper voice or voids. So I think
everybody needs to be thinking about communication and facilitating communication. And one simple thing you can do is on your ICU or tracheostomy ward is have a nice trolley with all of your resources available at the bedside. So charts, iPads with sensible apps that are not too heavy in terms of cognitive load, and you know, any simple things that you can use with patients. And obviously PPE's made it all a lot harder to do that. But
Brendan, we have a trachea team at our hospital. Is there a performer that that we use, main issues or factors that you discuss on ward round that others could maybe take back with them?
Yeah, certainly there is, and you know, it does evolve over time and depends. We've had paper versions, electronic versions, but we try and go through each of our sort of focus areas as perhaps me as the sort of physician, and we've got Barbara's respiratory physiotherapy hat on, and then Sarah's speech input, the nurse, and of course the patient, and then anyone else that needs to be involved. And you know, that document is available. It just tries to make sure that we tick all the boxes, and it's amazing the amount of things that we realise that we've not done, and checklists and formalising a ward round are really helpful. I'd be interested to hear from Steve and Ganesh actually about what happens in their hospitals with their sort of MDTs and bringing things together. So perhaps Ganesh, we could bring you in on that, and you know, the MDT in your hospital. I know you've got some strong ENT input as well. I mean, how does it work in your place?
Well, yeah, we've got a very strong team actually, as you say, multidisciplinary as well as multi-professional. I'd probably, to be honest, I'd be doing an injustice to them if I was to start spouting off about it, because it's not. But I think that's a strong message in that, and it's not just run sort of from within ICU, and provides very good ward service as well. So I won't go into too much detail because I don't want to get things wrong, basically. but yeah, but you're right, and we're lucky to have everyone involved in that.
And Steve, down in the Austin, we know Tanis has talked to us already about the TRAMS service, but do you get the multidisciplinary team involved while the patients are still on the ICU?
Yeah, absolutely. The transition of care certainly starts to occur prior to the discharge. I think, like many units, we have a very structured checklist to make sure that we don't overlook the essential housekeeping, but very important elements of our day-to-day care, which can easily be overlooked when you're busy, especially, or stressed as we are currently with our workload. And also a very structured handover that is multidisciplinary. So the physiotherapists will engage with the TRAMS, the medical team will engage with TRAMS, our nursing bedside team will engage, so that it's a very comprehensive transfer of care, because these patients are generally going to be quite complicated, and doing it right is the right thing for the patient, keep them safe, and also facilitates the discharge at the earliest safe opportunity.
Lovely. Barbara, another one for you. Patients who are respiratory wean, people want to know, do you perform physical exercise whilst they're doing their respiratory wean, or do you increase their pressures, or do you do day on, day off? Can you tell us what you do?
Depends on the patient. Every patient is different. You can't you can't say use an approach that, you know, one real for everyone. So we obviously, before we treat a patient, we do some physical exercise with them. We look at all the vital signs, blood gases. We see if they're reacting well to the sprint wean. If they started sprint wean as well. Obviously, they started like 10 minutes ago and they're not doing well. We're not going to say, hey, come on, let's start and stand up and do any physio. We wait for everything. When the patient is settled, when everything is well, you know, well settled and they're doing it, then we can look into that. But every patient is different from each other. We also, there's some days the patient doesn't want to do anything. We let them rest. You know, a day of rest doesn't hurt anyone. So it's a very tailored approach to every patient that we got. Everyone is different.
Sarah, this is quite an interesting one. Okay. Have you found that there's been a lot of upper airway complications and more profound during the COVID pandemic, and what ones have you kind of come across?
Yeah, definitely. I think it's been a big issue, and it's been something that's actually done my profession a bit of a favour in a way, because it's really highlighted the need for speech and language therapy input with patients who've got, you know, quite significant voice problems and swallowing problems that can take quite a long time to recover. But the sort of things we've been seeing are multiple laryngeal complications like edema, swelling, vocal cord palsies. We see these things anyway from intubation, but we've seen them occurring in, more so. I think every patient that we've seen in the second and third waves, we have done FEES and endoscopy and seen a complication in every single trachea patient. We've seen strange ulcerations, all sorts of things, Brendan, as well, haven't we, that can have taken a little bit of time to heal. And I think it's largely because these patients have been intubated generally for longer periods. They've been potentially had several tubes, having had a failed extubation and had proning as well. And also COVID itself, I think, is causing laryngitis and lots of erythema and redness and other things that are COVID specific, I think. Do you agree?
I do, yeah. This is something we could continue forever, but unfortunately we've run out of time for this panel session. I know this is something that Ganesh and Steve, they're all trying to coordinate intensive care in their countries have seen and they're aware of, but unfortunately we need to bring this session to a close. I'd like to thank Ganesh and Stephen for giving up their time to prepare their talks and for joining us on the virtual sessions, particularly given the time zone differences. So thank you both very much appreciated. I'd like to thank the sponsors for this event as well. Again, we couldn't do this without our sponsors, our platinum sponsors, Smith Medical and Atos, our gold sponsors, Capitex, and we also have bronze sponsors for Genesis, DP Medical and Fisher & Paykel. You can visit all of our sponsors in the virtual exhibition hall, and we'd encourage you all to drop in and see their products and see how our sponsors support safer and better care all over the world. There's a lot going on during this symposium, whether you're watching this session live or on demand. Please check out our virtual ward round game where you can play as a team or individually and try and get to the top of the international leaderboard. You can visit our poster gallery and see the abstracts, posters and video abstracts from presenters from all over the world. There's a Visit Manchester booth to give you a taste of what it's like being here, because we wanted to hold this event face-to-face originally, but we're trying to make the best of it with a virtual booth. But finally, as we close this session, we'd like to recognise one of our speakers. Tanis Cameron is retiring after 20 years of pioneering tracheostomy quality improvement work at TRAMS in Austin Health down in Melbourne, as you've heard throughout this session. So I'd like to close this session with a short video reflecting on Tanis and her team's accomplishments. Goodbye, Tanis. We'll miss you.